FFPI, I welcome all the delegates. Very soon we are starting our first session. Good morning and welcome. Starting our first session. It is a KT Hospital Symposium. I invite Chairperson Rajendra Pandya sir from Rajkot. Dr. Bhupendra Chavda from Surat, Chairperson. Please come on stage. Next, sir. I invite Dr. Jitendra Shah as a rapporteur of the session. Request our first speaker, Dr. Harjeet Singh Dunga. His topic approach to a case of acute breathlessness. Please welcome.
Good morning, friends. This is a nice way to start the session in the sense that upper respiratory tract infections are pretty common in this part of the country as well as this season. And usually breathlessness is a common symptom which all of you address. So this is a kind of symptom which all of you will encounter in your day-to-day practice, and hence it is very necessary that all of you have some standardized approach to treating this symptom which is very common in family practice.
Sir, excuse me, just to inform, this is session of 15 minutes.
Yes. So I'll be using a case to highlight the salient features about managing acute breathlessness. So this is my patient, an elderly male. He's been a heavy smoker in the past. He stopped around 5 years back. He's been a textile mill supervisor, so he has some occupational exposure, and he has several comorbidities. He's hypertensive, diabetic. He's been through an angioplasty around 5 years back. His LV function is fair. He has some history of allergic rhinitis also. He's got preserved exercise capacity. He used to go for a walk 2 kilometers every day till 6 months back. And since last 6 months, he's showing progressive worsening in breathlessness. He's now barely able to walk a few meters, and he's lost some weight as well. Along with this, he also complains of dry cough and edema. Over the last 1 week, he's had an acute febrile illness with further worsening in the breathlessness in the last few days. When I go to see this gentleman, he's orthopnic, he has a respiratory rate of around 26. He's hemodynamically stable, but what I notice is his saturation is around 88% on room air. Chest examination shows few valves and bronchi. There is a systolic murmur in the cardiovascular examination. He's fully conscious oriented. He's a 68-year-old gentleman. These are some of the medications which he is on. He got an X-ray done a few days back as a part of workup, and you can see that there is bilateral basal haziness and there is bilateral CP blunting. So this was my provisional diagnosis when I saw this patient. He could be having a respiratory condition like asthma, COPD. He could be having cardiac issue like congestive heart failure. He could have embolized. He's an elderly man and he's become bedbound. Or this has been precipitated by a viral pneumonia. So breathlessness, like I said, is pretty common in the usually day-to-day practice. What we mean by breathlessness is subjective experience of feeling discomfort, and this can vary from patient to patient because it is a subjective feeling. In the list of symptoms which are disabling, pain is the most disabling and breathlessness is the second most common disabling symptom. So it is very important that you address this symptom to optimum. Why? Because it has a bearing on quality of life, it affects the exercise tolerance of the patient, and it also has a bearing on mortality. So severe the breathlessness, more the mortality. Around 25% of elderly people, around 70 years of old, will complain of these symptoms. The general average is around 10% of your family practice will have patients of breathlessness. Remember, when one thing, as a patient ages, the patient should not be complaining of breathlessness. So aging and breathlessness is not synonymous. So every patient who is 65 plus, if he complains of breathlessness, treat that as a symptom or disease rather than attribute it just to aging. Always remember that breathlessness could be something besides breathlessness. So it could be an angina equivalent. In patients with fever or pregnancy, you can have just tachypnea. Some patients will have malingering and hyperventilation. So the first thing which you do is identify whether the breathlessness is a true dyspnea. The second thing is you need to know whether it is acute or chronic. Why? Because upfront you need to know what are the kind of investigations you can do. So in a chronic patient, you have the luxury of time and you can subject the patients to several investigations which can be time consuming. But in the acute scenario, you have very little time. So you have to be precise about which investigation you can do, and these investigations have to be extremely specific, so they should be leading to a diagnosis because your management is going to be very sudden. These could be in the form of ECGs, X-rays, sonographies, some biomarkers, and the pulse oximetry has changed the management of breathlessness. So these are some of the common causes which you will encounter in day-to-day practice. Amongst the cardiac causes, acute coronary syndromes and heart failures. Amongst the respiratory causes, asthma and COPD exacerbations, pneumothorax, embolism, and common infections like bronchitis and pneumonia. There could be some non-cardiac and non-respiratory causes like psychogenic and deconditioning, and always remember that severe anemia can also lead to breathlessness. So how do you move forward? The first is important. So the first and the most important is history. So you need to know the character of the breathlessness and what are the associated signs and symptoms. So what do I mean by character? First and foremost, the onset. So if it is very rapid and sudden, usually you think of acute coronary or an embolic phenomena. If it is gradual, then you can think of all chronic diseases. The duration. So if it has been happening over months or years, it is usually an acute exacerbation. So it could be acute exacerbation of asthma, COPD. It could be acute worsening of heart failure. What is the pattern? What do I mean by that? If the patient complains of orthopnea, usually you think of cardiac causes. If you have as a patient of platinum, where the patient gets breathless on sitting up, then you think of causes like ASDs, shunts, you can have pulmonary AV malformations and stuff like that. Sometimes patients have breathlessness on bending forward, that is called bendopnea, usually seen with overweight people, so it could just be a physical deconditioning affecting it. Sometimes breathlessness will be triggered, so viral infections, pollens, allergens will trigger respiratory problems, while fever can trigger a cardiac disease as well. The intensity will dictate how rapidly you need to manage these patients. Very importantly, what are the associated chest flank chest pain, you think of pneumonia, embolism, pleural effusion. Similarly, hemoptysis is primarily a respiratory symptom. Similarly, fever and weight loss is a respiratory symptom. So all the associated symptoms along with breathlessness will guide you as to the etiology. Last but not the least, what is the drug which relieves the breathlessness? So if it is a sublingual sorbitrate which relieves the breathlessness, it is of cardiac origin. If it is a diuretic which relieves the breathlessness, it is cardiac failure. If it is a bronchodilator which relieves the breathlessness, it is respiratory. So sometimes the drugs will help you identify what is the cause. So once you have assessed this patient from history, the next and the most important is to classify it, whether it is cardiac, whether it is respiratory. Second, you need to assess the severity. And third is you need to confirm the diagnosis. So this is how you usually do it. Cardiac causes, cough is not a dominant symptom. Orthopnea is common. There will be edema. You will have reduced urine output, and that will benefit with diuretics. In pulmonary side, cough is usually a major symptom. Hemoptysis might be frequent. Fever, weight loss, chest pain might be other symptoms, and usually these patients will not respond to diuretics. So simple 24-hour trial of diuretic will also give you some inkling. Next is you need to look at what are the risk factors, because the risk factor is a guide to the cardiac or respiratory cause of breathlessness. So if the patient has diabetes, if the patient has a background of hypertension, smoking, patient has obesity, patient has a family history of cardiac illness, these are common risk factors for cardiac cause. If the patient is immobilized, has had a recent surgery, is pregnant, has been using hormonal oral contraceptive pills, or has a past history of DVT, then you suspect venous thromboembolism. And if the patient has history of smoking, occupational exposures like silica, asbestos, or patient has worsening following allergen exposure like birds, dust, these are common risk factors for respiratory causes of breathlessness. The past history is also a good guide. So if a patient has IHD in the past, a coronary artery disease or a valvular heart disease, obviously you attribute the breathlessness to that cause. With a background of asthma, COPD, usually it is respiratory. Some common things which you need to know. Cyanosis is usually seen with respiratory causes, not commonly seen with cardiac causes. Fever obviously should indicate a respiratory infection, not a cardiac issue. And similarly, when you auscultate, murmurs will lead to identifying of cardiac causes, but rales and bronchi can be common to cardiac or respiratory. So just because you have rales, it is cardiac. If you have bronchi, it is respiratory. Please don't believe that. Usually you assess severity with the NYHA classification in cardiac causes and the MMRC classification in the respiratory causes. But these are usually implemented when you have the luxury of time. So when you are dealing with an acute scenario, the pulse oximetry is the best way to assess severity. One thing which I would like to point out is, whenever you do finger pulse oximetry, look at the waveforms. If the waveform like in the bottom graph are not accurate, the saturation is not accurate. So when you are using finger pulse oximetry, always look at the graphic of the pulse. Only then will it be considered reliable. Anything less than 95 is an indication of pathology. If the patient desaturates on walking by more than 5%, then it is a pathology. So this patient had symptoms, our case, of cardiac as well as respiratory problems. So this disease was still not clear. So we asked for a few investigations. Some of the investigations which came back indicated that BNP and tropi were, the BNP was high, his creatinine was high, and basically his D-dimer was high. So these are some of the investigations which you usually do in X-ray chest, ECG and echocardiography. But what I would like to highlight is, in the newer scenarios, a BFT and ABG should also be asked for when there is luxury of time. And today we rely a lot on what we call biomarkers. And these markers are some of the investigations which all of you can send in the acute setting, which help us decide whether this is a cardiac cause or a respiratory cause. So a D-dimer for embolism, a BNP for heart failure, a tropi for acute coronary, and a procalcitonin for infective etiology. A PFT cannot be done in acute breathlessness, but a spirometry, a peak flowmetry can be done. All of you can establish this in family practice. So if you are suspecting a respiratory cause of breathlessness, a simple peak flow will give you a guide to the severity of exacerbations. I know it is difficult for you to assess ABGs, but all you need to know is, if the pH is less than 7.35 on the ABG, and if the PaO2 is less than 60, please refer this patient for acute care in an emergency, because these are the patients which need immediate care. You can also look at a procalcitonin level. Remember, a normal procalcitonin level indicates a viral infection, but a high procalcitonin level indicates a bacterial systemic infection. So sometimes a PCT can be a guide to differentiate between infective and non-infective conditions. All of you asked for D-dimers, and in the COVID times there was an excessive emphasis on treating D-dimer levels. D-dimers are absolutely non-specific investigations. So just a positive D-dimer does not indicate pulmonary embolism. You have to follow it up with a more specific investigation like CT pulmonary angio. It can be positive in a lot of conditions. So please don't chase D-dimers with anticoagulation. So this is what I have just said. You can start with a peak flow. You can look at a pulse oximetry, and you can look at ECGs at the bedside. This will help you decide on what is the etiology. Secondly, you can look at a chest X-ray. It will tell you a lot of things. You can look at CBCs. A hemoglobin low will help you guide to anemia. And you can look at a BNP. So if the BNP is less than 100, it is a non-cardiac cause. If the BNP is more than 500, it is a cardiac cause. In between the two, you need further investigations like an echo. So this patient had an elevated BNP, elevated D-dimer, and elevated creatinine. But it was still not clear what we were dealing with. It could be a list of things. So some further investigations will be needed in a few patients. Till now, 50% of your patients would be diagnosed with these limited investigations. This patient was started on anti-failure, insulin, antibiotics, and nebulized bronchodilators. Next, there are two investigations which are left, which should be taken care by, which should be done only if your bedside assessment with the previous investigations have not yielded a diagnosis. One is a CT scan, the second is an echo. Now remember, a lot of CT scans were being done in COVID times. It is an investigation where you are exposing a patient to a lot of radiation. One CT scan is equivalent to 100 X-rays. So please remember, please do not subject patients to needless CT scans. It increases cancer risk. The cardiac ultrasound, the echo, and the lung ultrasound is an excellent non-invasive technique in today's world. A single investigation by a qualified radiologist will tell you whether there is a lung pathology or a cardiac pathology. So more and more use of ultrasounds in respiratory and cardiac practice today. So if you have a good radiologist whom you can access, a lung ultrasound and a cardiac ultrasound will give you etiology of acute breathlessness. Plus, it is a bedside investigation, so it can be done even at home in certain situations. When we looked at this patient, his LV ejection fraction was 40%. He had a dilated right heart and he had severe pulmonary hypertension. This indicated more of a respiratory cause of dyspnea. So we did a CT scan also. Now if you see the CT scan, there are lots of pathological findings. This patient has emphysema and it has basal fibrosis as well. Now this is an entity which we call combined pulmonary fibrosis emphysema syndrome. So this patient, although had a background of IHD, LV dysfunction, but when he worsened, it was a respiratory etiology where there was combined fibrosis and emphysema. This is an entity which is not very common. It is seen mainly in smokers and it is complicated by pulmonary hypertension, and sometimes patients can have lung cancer, and this is associated with very high mortality. So to summarize my talk, what have I taught you today? When you deal with a patient of acute dyspnea, first and foremost thing is to look at stability. If this patient is hypoxic, saturation less than 90, blood pressure systolic less than 90, heart rate greater than 120, please refer the patient to an emergency room for immediate care. But if the patient is stable, then you can subject him to sub-bedside investigations. This includes pulse oximetry, peak flow meter, and ECG. These can be done at the bedside by all of you. If those investigations don't yield the diagnosis, you can go for an X-ray chest and an ultrasound, which can also be done in bedside in a city like Afpa. Once you have something, you can also send biomarkers to confirm the diagnosis. If your diagnosis is still not confirmed, then you subject the patient to a CT scan. So that is how you approach a patient of acute breathlessness in 2023. I thank you for patient listening.
Thank you, sir, for a nice lecture. Please, 1 minute, sir. I request Dr. Rupesh Chawda. I request Dr. Jitendra Shah to felicitate Dr. Arjit Purva, sir. Sure. I request Dr. Karthik Desai, gastroenterologist. Guys, today's subject is NAS vulnerable. I can start with that. Session will be for 15 minutes. Okay. I'm going to answer in a few minutes regarding is the nation vulnerable. Is a future of India will be will a burden of the nation or not. So I'm going to deal this topic in the definition, diagnosis, treatment, and summary. Starting with the case. Case 1, where 30-year male IT engineer, basically sedentary lifestyle, came with a ultrasound report of grade 2 fatty liver and elevated liver enzymes, which where his BMI was 31 kg per meter square and he had abdominal obesity with significant family history of father having diabetes mellitus. While in the case 2, 35-year male marketing executive, so he doesn't have sedentary lifestyle, came with a cheap complaint of grade 1 fatty liver and discomfort in abdomen after having food with BMI of 26 kg per meter square and no significant family history. Coming to the definition, NAFLD, that is non-alcoholic fatty liver disease, encompasses the entire spectrum of a fatty liver disease. While non-alcoholic fatty liver, where presence of the more than 5% of the hepatic steatosis is known as hepatocellular without any evidence of hepatocellular injury. While NASH, that is non-alcoholic steatohepatitis, the name itself suggests there should be a fat as well as presence of the inflammation, where you have a ballooning degeneration of the hepatocytes and with or without fibrosis, and this can lead to the cirrhosis, liver failure, or hepatocellular carcinoma. So how do you diagnose this? You should have 4 things in the diagnosis: evidence of hepatic steatosis by imaging or histology, no significant alcohol consumption, no competing cause of hepatic steatosis, and no coexisting cause of the chronic liver disease. First, evidence of hepatic steatosis. Histology is a gold standard, but usually is to rule out other etiology and for more definite treatment if there is a non-invasive marking showing F3 or F4 fibrosis. So what we come across in the routine practice is a ultrasonography, where in the first 1A and 1B figure, it is grade 1 and grade 2 fatty liver, where liver is looking more brighter than the kidney, while grade 1C and 1D are grade 3 fatty liver, where you cannot appreciate diaphragm as a different, and you cannot appreciate diaphragm as a different entity, as well as the muscular markings are also not well appreciated. So next thing is a fibroscan, where detect liver stiffness well, and more than 12 kPa stiffness suggests F3 F4 fibrosis. Ultrasound elastography is now available in each and every modern machine. If you don't have fibroscan, at least you can suggest ultrasound elastography. MR elastography at presently not done in the Gujarat. This is a very good test, FIB4 score, where you have age, ALT, ST, and platelet counts, and this is available calculator on the online, and you can, if it is FIB4 score is less than 1.32, there is 90% predictive value of there is no advanced fibrosis, and you can screen this patient via this during your routine clinical work. While FIB4 score more than 3.25, 97% specificity, and straight away this patient require a lot more evaluation. Here also in the stiffness graph, if it is between 2.5 to 7 kPa stiffness, it is F0, F1. But if it is crossing more than 7, you should get alert. This patient requires further evaluation and better management. Coming to the no significant alcohol consumption, according to Asia Pacific guideline, 2 standard drinks for a meal and 140 gram per week of the alcohol. in the woman 1 standard milk per day and 70 gram of the alcohol per week. No company does a hepatic steatosis. There is a list of the problem, but remember alcohol, hepatitis C, Wilson's disease, and medications. No coexisting chronic liver disease. This is very important. You can get hepatitis B and C with them with the elevated liver enzymes. Wilson disease also come as a fatty liver and of course alcoholic liver disease. So now coming to the problem. Prevalence of the NASH. This is a study from the Lancet in 2022 and India is around 40% of the patient having NASH in around entire population. So it is a very, very big number. And among the type 2 diabetes, it is around 60% to 70%, 60% of the population having a NASH. So this is also a big number because India is the highest number of the diabetes mellitus. And this is a UNICEF World Obesity Atlas in 2022, and they have predicted that by 2030, 1 in the 10 of the children globally will be from the India. So this is a very big number, and that's why, yes, we are vulnerable. We are vulnerable to this problem, and what we can do in this at the very basic level. So, the subsequent part I am going to discuss regarding what are the risk factors, clinical features, and how we proceed with the diagnosis and treatment. Always see age more than 50, obesity, diabetes, ethnicity that doesn't apply to us, and hypertension. So any patient who has metabolic syndrome in short should be screened for the hepatic steatosis and NASH. ALT, AST approaching up to 1 should never apply to one investigation, just SGPT. You do both SGPT and HGOT both. If possible, liver function test would be good in these patients. And see here, serum AST level, that means SGOT more than 40, it is actually a sign that your liver is getting damaged rather than SGPT. Symptoms, most often they are asymptomatic, they can have fatigue, upper quadrant pain, due to obesity, obstructive sleep apnea, polycystic ovarian syndrome, and they can have hepatomegaly, acanthosis negligence. So good basic examination of the patient is very, very important. Always remember the metabolic syndrome panel, and out of these 5, 3 should be fulfilled, and you should and stop taking. Very important. See here, this is a study from NEJM in 2021. F0 F1 fibrosis, there are less chance of varicose bleeding, ascites, and encephalopathy, hepatocellular carcinoma. Once you have more than F2 fibrosis, F3, F4, then you have in the multiple complication and also mortality rate goes higher. So, what is the natural history of this problem? Fat in the liver, more than 80% is isolated fatty liver, nothing to worry, just tell them to do a lifestyle modification, good exercise, and good food. Less than 20% goes into the NASH, 11% over 15-year growth change into the cirrhosis, and 30% in the 8 years change into the decompensation. And HCC, news directly also coming with the HCC. So this is the next concern. HCC can occur without presence of the cirrhosis in the NASH. And this is one of the biggest concern at this point of the time. 5-fold increase in HCC risk in absence of the cirrhosis when the NASH or metabolic syndrome is present. And main risk factors are advanced, that means more than 50 years of the age, male sex, diabetes, and obesity. And here you see, India has the most number of the patient of HCC due to NASH or obesity-related NASH, obesity-related HCC. Coming to the treatment, so you have to treat systemic hypertension, diabetes, and dyslipidemia. These are also cornerstone of the treatment, but I cannot cover in this point of time. Coming to the diet, 30% reduction in overall calories. So somebody is eating 5 chapati, you tell them You eat only 3 chapati, very simple, and rest of the part should be fruits and vegetables. Okay, fructose containing foods or beverages should be avoided, and polyunsaturated fatty acid advertised by many food companies, but it doesn't have a good evidence to help in the reduction in the liver fat. This is a Mediterranean diet, lots of guidelines advising. In the Gujarat, you should focus on this part. Lots of vegetables, fruits, whole grains. Olive oil we don't have, but our olive oil you can say mustard oil. It is our oil, olive oil. Beans, nuts, legumes, seeds, herbs, and spices should be included in our diet. Exercise, aerobic exercise, that means cycling, walking, swimming, or running. 40 to 60 minutes per day, 5 days a week. 70% of the maximum heart rate. So 220 minus 8, whatever the number is coming, that you should go up to the 60 to 70% of the rate. Very simple way. You should have perspiration, or you should not able to speak a full sentence after walking or running. That is the achievable heart rate. Achievable heart rate. Weight reduction can be achieved up to 10%, and in this study from Dusage et al., 64% out of 100 have complete biochemical response. Coming to the weight loss, 3% of the excess weight loss, steatosis can be reversed in 35 to 100%. Weight loss more than equal to 5%, you can reduce inflammation in 41% to 100% patient. And weight loss more than 7%, 64 to 90% can have a resolution of the NASH. And weight loss more than equal to 10%, fibrosis can be reverted in the 45% of the patient. So coming to the weight loss part, physical activity very good, up to 10% you can achieve weight loss, but it is very difficult to adhere. And medicine, more than 5% weight loss, if you can achieve in the 3 months of the medicine, it is a good to go ahead with that medicine. And the new drug has come, that is semaglutide, GLP-1 RA analog, but 2.4 milligram per week can achieve up to 10 to more than 20% of weight loss. And these are the 3 studies came into the JAMA, and Endocrine Association, International Endocrine Association have recommended this treatment at this point of the time. Of course, bariatric surgery, key factor in the management of the obesity. BMI 32.5 kg per meter square, or BMI more than 30 kg per meter square with comorbidities. In Asian descent patient, you should go ahead with the bariatric surgery also. Medicines, vitamin E, reduce NASH up to 30% of the patient, important for the non-cirrhotic, non-diabetic patient, but increase in the mortality, risk of hemorrhagic stroke and prostate cancer. Metformin, reduce the risk of HCC. Pioglitazone, good drug, but you can use only in the diabetes patient. Weight gain, bone fracture, and congestive heart failure are the adverse effects. Semaglutide, once again, is also reducing the steatosis and hepatitis. Coming to the primary caretaker awareness, this is a very good study, came from the American Journal of Gastroenterology 2015. Check out the prescription of these primary care physicians. 20% sure the possible diagnosis of the NASH, 15% sure written the diet and exercise should be undertaken to reduce this problem, and only 3% refer to the specialist with a high risk of the fibrosis. So yes, we also need to get aware of this problem, and we need to check most of the patient with high risk factors. Few words about the lean NASH, where BMI is less than 22 kg per meter square. It is known as lean NASH. This is a totally opposite of the obesity, and now there are many things that metabolism is actually a problem in these patients, and they get a steatohepatitis. All the things, all the mortality are higher in the lean NASH than the obese patient. But yes, in India, it is most common. One of the most common problem in India in the steatohepatitis is also on lean NASH. Lifestyle measures are cornerstone of the treatment. The new treatments are yet to come. Yes, sir. So coming back to my first case and second case, the first case has ALT and AST of more than 200. FIB4 was 1.94, in elastography showed 9.24 kp of the stiffness. We worked up him for the other causes, so his smooth muscle antibodies were positive, so autoimmune hepatitis we thought associated with that. Liver biopsy we did for this patient, it showed steatohepatitis sorry, and F2 fibrosis. They've given him a chance for vitamin E and lifestyle modification for 6 months. Still, his enzymes were on the higher side, and we plan to go send him for the bariatric surgery because he is in F2 fibrosis. We don't want to send him to F3, F4 because F3, F4 has a higher rate of the complication in case of the NASH. While the case 2, ALT and AST were within normal limit, FIB4 score we have calculated which was 1.34, less than 1.34. We advise him for the lifestyle modification and follow up after 3 months. So, summarizing, always look for a metabolic syndrome. Be careful with the diabetes patient. They can have underlying NASH. Check T4 score at your clinic. Higher than 1.32 or liver stiffness measurement more than equal to F2 fibrosis. Refer to an expert. Otherwise, if T4 is lower than 1.32, lifestyle modification for 3 months and recheck them. So please be aware of the problem, and we are going to deal with this in a long-term time. As well as the most common cause of the liver transplant would be NASH in next 10 years. Thank you very much. Thank you. Thank you very much, Dr. Karthik Desai, sir, for giving nice lecture. I request Dr. Bhupesh Chawda, please, take a moment to Dr. Karthik Desai, sir. So, Dr. Ashish Kaushal to take a lecture. Subject is a case-based approach to the cytopenia. Good morning, everyone. I think this is one of the very common topic what we are discussing today. We've seen a lot of patient in the family physician practice. They present with some kind of separation of the one of the series. Sometimes there may be more than one series involvement. So cytopenia is very common, and whenever we see this kind of the patient in practice, I think we need to look for the right approach because the cytopenia management is sometimes challenging because it is basically a tip of the iceberg in some cases, and there are underlying disease which may be life-threatening in certain patients. So, what is cytopenia? I think most of the people are aware, but just the basic understanding. The patient can present with anemia, which we all know, so reduction in RBCs. Leukopenia. So leukopenia is a WBC count deficiency, especially if there is a neutrophil deficiency, it's called neutropenia. And neutropenia is very important because in some patients it can be grade 4 neutropenia where the absolute neutrophil count is less than 500. Thrombocytopenia, you have seen a lot of patients in the dengue fever, they come with a low platelets, so thrombocytopenia is a deficiency of platelet. And
So what we are discussing mainly today is the pancytopenia. So pancytopenia is basically the suppression of all the three series that includes RBC, platelet and WBC count. And specific differential diagnosis for cytopenia, you can see the common diagnosis can be a vitamin deficiency, the infection, or sometimes maybe underlying malignancy which can be presented with the cytopenia. So just to understand very easy in terms, I think in some of the cases which is very similar kind of the cases. Just we need to focus what are the findings in that. The first case is a 21-year male. You can see the patient having history of tiredness. That's the only symptom. Might weakness, tiredness without any history of any fever. And the patient underwent the CBC. And the CBC suggestive of pancytopenia, HbS 5, WBC of 2,600. Neutrophil count is 1100 and the platelet is just 45,000 and the MCV is 104. Looking to the PS pancytopenia with MCV of 104, but the patient was subjected for the vitamin testing, the B12, folic acid, and ferritin were normal. And clinical examination is unremarkable. There is no organomegaly, no lymphadenopathy. So it's a very common kind of presentation. The only thing is patient the pancytopenia. So in this series, what will be the tentative diagnosis? You can see. So people believe, anybody can read it? What could be the line? Iron deficiency, the iron ferritin was normal. MCV is 104. So a lot of differential diagnosis, and I think in this slide it is very difficult to approach. The only thing what we can exclude are vitamin, which is one of the common is B12 folic acid is normal. So patient underwent bone marrow biopsy. And you can see the bone marrow, what is the in bone marrow? It's a hypocellular marrow and mainly replaced by fat cells. So the diagnosis are mentioned right. This is a diagnosis of aplastic anemia. The bone marrow is hypocellular replaced by the fat cell, and there is no abnormal cell. Sometimes what happens? There is a fibrosis, but there is abnormal cell. It could be a differential diagnosis, myelofibrosis. So this is a very the similar case. Same patient, 21-year male, I could say, presented in different way. History of tiredness, no fever. The same WBC, same hemoglobin, same platelet, MCV 104. Here is iron ferritins are normal. Examination is also unremarkable. What would the diagnosis? Here, the B12. You can see in the PS, this is hypersegmented neutrophils with the megalocytes. So the diagnosis is megaloblastic anemia. So here, the B12 and the folic acid can come from this, and sometimes you've seen the patient actually they receive a vitamin B12 injection 1 or 2 days prior, and they report you do the blood test, and I think this in that case is the B12 and folic acid can be normal. So we have to wait for some time, and in this case there is no abnormal. The case 3, which is almost the similar, 21-year male, history of the tiredness, but here is history of fever. The same HbS 5, WBC 2,600, neutrophil is 1100, platelet is 45,000, MCV is 85, B12, folic acid, iron ferritin are normal, and dengue antigen also negative because iron antigen is low down because of there is history of fever. Clinical examination revealed mild splenomegaly, no lymphadenopathy, and patient was received vitamin supplementation antibiotics without any response. What we did tentative diagnosis in this case? Anybody can predict? Drug induced splenomegaly, drug induced chronic malaria, pancytopenia and malaria, not Natcon. So we look for more common thing. pH suggestive of atypical cells, which suggestive of myeloid blast. And this is the diagnosis of acute myeloid leukemia because the match is confirmed by bone marrow examination and bone marrow suggestive of myeloblast. Whenever we see this kind of a patient, not only the diagnosis is very important, we need to look for the certain more analysis in terms of the immunophenotyping that is called flow cytometry and the cytogenetics. And this flow cytometry is very important because sometimes what happens in the morphology, we look for acute myeloid leukemia, sometimes it is acute lymphoid leukemia. So flow cytometry can differentiate between the different kind of the leukemia because there is a different expression of the antigen. And the cytogenetics is very important. We need to look for the entire panel because nowadays the diagnosis statement is based on the prognosis, and prognosis can be depend on the cytogenetic analysis, whether the patient is in the good race, poor race, or intermediate race. And sometimes the patient is so in poor race, we need to give the transplant in upfront scenario. Case number 4, similar kind of the picture. The 21-year male patient is history of petechial spots without any fever. So here, the patient has a WBC is almost a normal, HB is little low, 9, the neutrophil is okay, the platelet is very low, 15,000. And the same patient having the similar B12, folic acid, ferritin normal, the antigen was also tested because of there was because of the petal spot, but there is no fever. And the clinical examination other than petechiae was normal. What would be the diagnosis? ITP. This would be more likely ITP, but ITP sometimes we need to look for the exclusion because sometimes what happens there is a viral suppression. So if there is a patient having history of fever, sometimes there is any kind of viral suppression, I think we need to look for a more workup, but bone marrow suggestive of normal marrow megakaryocyte. Right? So that is the one of the mandatory for ITP, and ITP is require a good prognosis. The case 5, 21-year female, here is the female patient, other man. The patient presented with a fever and rash. HB7, WBC 1600, neutrophil 1100, platelet 15,000. You can see there is a pancytopenia with history of fever and rash. Ferritin, we have a lot of COVID scenario with a lot of patients having ferritin and CRP high, but here the ferritin high is SGPT is moderate elevation 250, and the patient has a high triglyceride and low fibrinogen. And examination revealed mild hepatosplenomegaly. What is the diagnosis? Anybody can? Ferritin, high triglyceride, low fibrinogen, anybody can get clue? So hepatosplenomegaly, low fibrinogen. So this is basically HLH. So bone marrow exam, it's a risk about hemophagocytes, and this is a diagnosis of hemophagocytic lymphohistiocyte. So it's a diagnosis exclusion, but whenever we have high ferritin, there is a criteria. So for hemophagocytosis, actually the patient is having pancytopenia, the patient has a high ferritin, more than 500 is mandatory, high triglyceride, low fibrinogen, abnormality of renal kidney function may be associated. Splenomegaly is one of the criteria, and bone marrow or spleen suggestive of hemophagocytes. So that would be the 5 criteria at least to be required for diagnosis HLH. Case 6. 65 year elderly male. Tiredness without any fever. HB is 5, WBC is 4,600, neutrophil is okay, platelet is 45,000, MCV is 104. B12 folic acid, ferritin normal, examination normal. Differential diagnosis. B12 is normal. Mainly. Bone marrow examination is must. He is elderly male, so we need to look always in elderly different picture. So bone marrow suggests of dysplastic marrow. So this suggests of a myelodysplastic syndrome, which is a pre-leukemic syndrome. And the cytogenetic analysis is helpful because in the good cytogenetics, we need to give some target therapy, otherwise bone marrow transplant if the patient's physical condition and comorbidities allows. 65 elderly male, history of tiredness and backache. HB7, WBC is okay. Platelet is a little bit low, 85,000. Vitamins for iron and ferritin okay. Mild elevation of the creatinine and calcium is 10. And excess evidence of lytic lesion in the spine. So this would be the early symptom of the myeloma. Bone marrow suggests of 40% plasma cells. Monoclonal band in serum protein electrophoresis can confirm this diagnosis. We can do the light chain assay, and if there is a light chain and abnormalities, then we can find a kappa or lambda high, the ratios reverse. And this is a diagnosis of multiple myeloma, and which is sometimes it's missed because, just light lesion, people believe this is a metastasis, actually this is myeloma, especially for it. So this is common in the elderly patient, not in young patient. Case 8, 65-year male, urinary difficulty, and backache. HB is little low, WBC is okay, platelet 85, almost the same to the last case. Here is also B12, folic acid, ferritin normal, but rather than lytic lesion, here is sclerotic lesion. So this is the very important, just one finding you can find out which is diagnosed. So PSA stun 25, and the PSMA PET scan suggests a prostate lesion and multiple bone secondaries is the metastasis from the prostate, which is called myelophysis. So sometimes what happens, you have this patient who presented the backache, you did an MRI scan, and you find the patient having a lesion in the spine, and they mentioned it could be neoplastic. So what do you think comes to your mind? If the patient is elderly, there's a two most common difference: male patient prostate, or if there's a lytic lesion, we look for the multiple myeloma, which is very common in your practice. So what I discussed is the 7-8 cases which presented with the just mild to moderate pancytopenia. I think this is a common in all cases, so I'm not going for detail. With this, I thanks, and I think this will probably help us in diagnosing farms in Japan. Thank you.
Thank you very much, sir. Now I request Dr. Rajendra Panda to felicitate Dr. Ashish Kaushal, sir. Now I request Dr. Pragnesh Shah to the lecture. The subject is sex life after cardiac event. Session very soon because of the technical problem. You may wait for a couple of minutes. Sir, your session will be for 15 minutes. Please.
Yeah, thank you very much. Thank you very much, the organizing team, for organizing a wonderful conference. So this is something out of the box topic, which we are always send up or avoid to talk with the patients. But I think it is very important. Sex life after cardiac event. Why this topic? Because most young adults who experience an acute viral infection are sexually active before the acute MI. But little is known about sexual activity or sexual function after the event. Neglected area from both sides, from the doctor side and from the patient sides. Nowadays, heart diseases are very common in the age group less than 40 years. So, how many of asking a question about sex lives to post PTCA or post MI patients or any cardiac procedures patients? I think very less. So, this case is come to me. This is an incident of 2008 which pinched me to ask this question to every patient. Male 36 years, married life is almost 3 years, post PTCA to RCA, and ejection fraction is almost normal, 60%. TMT is 12 minutes without any symptoms, post PTCA 2 months. But there is a miss. The stent means sex not. So they have marital issues and divorce 8 months post PTCA. The reason is absence of sexual activity. So there is no counseling done from the medical practitioners. So what the medical science says? It is a very good article in the PubMed that cardiovascular changes resulting from sexual activity and sexual dysfunction after myocardial infarction. They conclude that because sexual dysfunction negatively affects the lives of the people, providing guidance to the individual with cardiovascular disease, especially after acute myocardial infarction, may be a crucial factor in determining quality of life and should be incorporated in clinical practice. The Manscaped in one article in 2020, they said that management of sexual dysfunction has traditionally been domain of the psychiatrist, urologist or gynecologist, but with the growing recognition of the sexual dysfunction and CVD, often coexist. The general practitioner and the cardiologists are now getting into the act. So the AHA in the wonderful article says, is sexual activity safe after MI? They says it may be safe to resume sexual activity following myocardial infarction, and MI is rarely caused by the sexual activity. The resuming sexual activity soon after heart attack linked with the improved survivals. This article said that returning to the usual level of the sexual activity within a few months after a heart attack is positively associated with long-term survival. So they said that if the patient resumes sexual activity after the heart attack, the survival will be increased. Sexuality and sexual activity are markers of well-being. Resumption of the sexual activity soon after the heart attack may be a part of the one's self-perception as a healthy, functioning, young, energetic person. This may lead to healthier lifestyle generally. Maintaining or increasing the frequency of sexual activity within the first 6 months after the heart attack was associated with 35% of lower risk of death compared with the absent or reduced frequency of the sexual activity. So they said that if the person is reduced sexual activity post MI, they have some decrease in the lifespan. The other article in the European Association of Preventive Cardiology, they concluded that reduction of the sexual frequency within the first month after the MI was strongly associated with improved long-term survival, highlighting the need of the sexual counseling shortly after the MI. So the simple message is ask, or if the patient is not asked, ask them about the sexual life post MI or post PTCA. This is a very good article in the Canadian Journal of Cardiology that they compare the different the component of the sexual activity and compare it with the walking. They said that kissing and touching is as good as we walk slow. Then other mode of masturbation and oral sex is it will consume energy we are walking at the normal pace. Then the sexual activity is a little bit faster. And when there is an organism, it is the faster when we are crossing the roads. So this is in the detail of this. Due to the time constraint, I will not discuss in detail. But this slide is very important, and I think everyone should in the practice. They said that patients with the high risk group, like the unstable heart disease and the ejection fraction is less than 30% with the symptoms. So they should advise that this is the Kitomi model. You can search on the Google about the Kitomi model and you can get it. So they said that it means kissing and touching is allowed. Like that, this is the Kitom word is sexual component, the first word. So this is a very good table. I request all of you to read and download from the Google. This is in the 2014, in the AHA journal, they said that without cardiac symptom, people can resume sexual activity within the 1 month or within the 1 or 2 weeks if there is no cardiac symptoms. said that coital angina is occurs during the, it is a term which is for the angina that occurs during the minutes or hour after the sexual activity represent less than 5 patterns in the anginal attacks. It is rare in the patient who do not have angina during the strenuous physical activity and more prevalent to the sedentary individual and severe coronary artery disease. It means the exercise is the, we should also advise patient to do regular exercise post cardiac event. If the patient can achieve an energy expenditure of more than 3 to 5 minutes without any demonstrating ischemia during the exercise taking, then the risk of ischemia during the sexual activity is very low. It means if the patient can walk or patient can climb one floor of the staircase without any symptom, it means they can achieve a workload of 3 to 5 minutes, so they can resume the sexual activity normal post MI. This is the recommendation by the AHA that sexual activity is reasonably for the patient with no and mild angina. Sexual activity is reasonable 1 or more weeks after uncomplicated MI if the patient is without cardiac symptom during mild to moderate physical activity. And sexual activity is reasonable for the patient who undergone complete coronary vascularization after the 6 to 8 weeks. They said that after the bypass, they advised to resume the sexual activity after the 8 weeks because the wound and the sternal wounds need time to regenerate. So that's why they said that 8 weeks. Then in all other the modality of the cardiac surgery like post-valve replacement or any form of cardiac surgery, when the sternotomy, the sternum bone is cut and suture again with the wire, they said that a patient can resume the sexual activity after the 8 weeks. Patients with arrhythmia and pacemaker, they can also resume the cardiac activity if they are able to perform the workload of 3 to 8 minutes on the TMT. It is reasonably good to resume the cardiac sexual activity in the patient with HOCM. Reasonable for the most patient with the HOCM. Sexual activity should be deferred for the patient with HOCM who is severely symptomatic until their condition is stabilized. Patient with the NYHA 3 and 4 dyspnea with the ejection fraction less than 30%, if they are first they must be treated with the pharmacological management and make them stabilize, and they should advise to rejoin the sexual activity. The cardiovascular drug that can improve symptoms and survival should not be withheld because of the concern about the potential effect of the sexual function. If some patients have a erectile dysfunction due to the beta blockers, and if the benefit and risk versus ratio we should compare, and if the benefits are more for the life, then we should not discontinue the beta blockers. For the herbal medicines, it may be reasonable to caution patients with cardiovascular disease regarding the potential for the adverse event with the use of herbal medication with unknown ingredients that are taken for the treatment of sexual dysfunctions. Here the patients and the partner counseling both are very important. For the PDE5 inhibitors, we are using left and right, and the very famous drug is Viagra for that. That PDE5 inhibitors are useful for the treatment of erectile dysfunction in the patient with the stable cardiovascular disease. The safety of the PDE5 inhibitors is unknown in the patient with severe aortic stenosis and SCM, but it should be cautioned that patient is not on the nitroglycerin especially. So counseling with the patient with the cardiac disease regarding the sexual activity and advice is must be the individualized. In general, if the patients are stabilized, they may resume normal sexual activity within 2 to 6 weeks. A graded TMT may be the value believe in the high risk group of the patient, clinician must be alert to potential medication effects that may be contributing to the factors of sexual dysfunction. Patients should be symptoms with the sexual activity should generate evolution. It means palpitation, shortness of breath, angina, fatigue, and alert that physicians should be they should inform the physician that this type of symptoms should occur. And finally, physicians should be proactive in assessing and counseling patients regarding sexually functioning activity. In general, last slide only. In general, if the patient can achieve 5 max on TMT without demonstrated any symptoms, they are generally not a high risk to resume sexual activity post cardiac procedure or cardiac surgery. Similarly, if the echocardiography does not yield evidence of more or moderate left ventricular dysfunctions, they can resume the sexual activity safely. Thank you. Thank you very much.
For this Dr. Padishri Shah. He is elected as a incoming president of FPI for next 2 years.
First of all, let me complete the first session. We are completing first session thanks to the all speakers, rapporteur and chairpersons. I request Dr. Pragna Shah to felicitate our rapporteur, Dr. Jitendra Shah. Request Dr. Dhiren Mehta to felicitate and our chairperson, Dr. Bhupesh Chawla. I request Dr. Dhiren Mehta to felicitate chairperson Dr. Rajendra Panja from Rajkot. We are now starting our second session of KD Hospital Symposium. If in the hall present, please come on stage, chairperson Dr. Dilip Kothari. Dilip Kothari from Surendranagar. And Dr. Suchismita Pathak from the Udaipur as a chairperson.
Hello. Now I like to call Dr. Gopal Shah on stage. He is going to enlighten us regarding the approach to a patient of head injury, right? So, and the session is for 50 minutes, sir. Thank you so much.
Yeah, good morning, ma'am. Good morning, everybody, and thank you, AFPA. This is my consecutive 6th year and privilege to speak in front of such an august audience. With kind permission of management and the organizers, I have changed the topic a little bit because there have been a few topics regarding the general management of neurosurgical cases and neurological cases. So I just thought I'll talk more about what are the new things happening in field of neurosurgery. So, like I am part of largest neurosurgical team in Gujarat. We are 7 neurosurgeons working together. There are no disclosures, no research grants, and no equipments company sponsoring this event. So, my talk is mainly, as I wrote, it is evolution in the field of neurosurgery. So, evolution means evolving from old to new, evolving from past to present, and going to the future. So, for a surgeon, like I am a neurosurgeon, I'll be talking about a surgeon first. These are the good qualities of a surgeon who should be trustworthy, with good communication skills, experienced, and good in decision making. But when you're talking about a smart surgeon, it's not that the surgeon are not smart, but a smart surgeon is learned, updated, uses the technology efficiently, uses the infrastructure very good, technologically he is trained, and he teaches. Like I know a lot of senior surgeons who were very good surgeons, very good teachers, but they never used to teach the students for XYZ reason. And the teamwork. As our team, Dr. Manish Khaitan, the bariatric surgeons team, we all work in a team. So there is no captain, there is no vice captain. It's all team working together with their own inputs. So at KD, we have I don't work like a neurosurgeon. We have got a neuroscience department. So what's the difference between neurosurgeon and neuroscience? So neuroscience includes a neurosurgeon, a neurologist, a neurocritical care specialist, a neuroradiologist, a neurorehab, psychology, ophthalm, ENT, and neurophysiology. And we are coming up with one of the state-of-art and first in Gujarat neurorehab center in KD Hospital in short future. Probably it will be launched by mid of this year. So evolution of a surgeon. So as you know, the human race has evolved, the animals have evolved, everybody has evolved. The surgeon has also evolved in last 2000 years, starting from the prehistoric era or a stone age, and now they went to the microsurgery, endoscopic surgery, and now it is the era of a digital surgeon. So same way, our history of medicine, our history of surgery dates back to before Christ, like it is BCE now. And these were beautiful instruments. They used to use endoscope even before 2000 years. So what we are doing now is not something a miracle. It is just a modification of what was available earlier. So these were the previous old instruments. These are the new instruments, and this is the new latest top-end operation theater. So when I say evolution, so as you all know, the surgical practice or surgical training, every surgeon is learning every day till the last day of his practice. So the first 5 years is like, enthusiasm. And then few of the surgeons, they drop out because they don't want to go beyond certain limit because of the risk, complication, and the poor outcomes. We are looking at practicing beyond 15-20 years and reaching this stage where you can learn new things, you are ready to take up complicated cases, and you will keep on progressing. And that's what we want in the field of neurosurgery, and that's what we want in the field of every branch of the medicine. So what are these new tools which are useful for good quality, good outcome neurosurgery? These are microscope, endoscope, neuromonitoring, high-speed drill. I'll just go through one case each for this, and that will, I hope that will make the things very clear in your mind. So first thing is, like, what is the difference between other part of surgical branch and the neurosurgery? When we open the abdomen, when we do a laparotomy, you got a liver on this side, stomach on this side, kidney here, everything is positioned properly, everything is shaped properly, color, everything is different. But when you open the brain, it all looks same. There is no difference between the motor area, speech area. So the neurosurgeons have been struggling to find a technology which will guide us. Where do we stand during the surgery? So this is like, you put a probe, this is a digital film, you put a probe here and it will tell you this is thalamus, this is hypothalamus. You can appreciate that everything looks same, just the functions are different. So then came the technology of navigation. So this is satellite based navigation that everybody is using today, Google Maps, Apple Maps and GPS. The same technology has come in neurosurgery, and we are fortunate enough that we are the first in Gujarat to acquire this technology. Now that we call it a stereotactic surgery. Now this is an old stereotactic surgery. It's not old, but it is still prevalent in most of the part of Gujarat. But this is, we used to use this earlier before 2 years, where a bulky frame is applied on patient's head and the coordinates are adjusted, and then the needle goes in the brain to take a biopsy or remove the tumor. Now with current technology, what I told, the neuro navigation, the things are changing faster. The 2D is going into 3D, the analog is going into digital. So this is the neuro navigation system. This is our operation theater. This is me and my colleague Dr. Rushabh Shah, and this is the whole system. The MRI is done in the hospital. The CD is loaded on this computer system, and in the operation theater we plan the surgery. So from where to enter, how deep to go, which direction to travel, because it's a 3-dimensional thing, X, Y, Z. So we have to plan in 3 dimensions. And then, so how it works? You can see, I'll show the video of this patient. This is awake craniotomy we are doing for a tumor in a highly intellectual triple graduate patient, and she's an entrepreneur, and she had a tumor on the speech area, which is in the left posterior frontal area, and removing the tumor inadvertently could cause permanent speech loss. So this is how we, this is our colleague, young doctor, Dr. Love Patel. So patient is awake, patient is not under general anesthesia, and we just doing the localization. See, if you can see the probe in my hand, the way I move the probe on patient's head, I can see the where the tumor is. So this machine can see through the head and it can locate the tumor. So I can open only small part of the skull. I can do only limited shaving and without major deficits. The same thing, I'm putting the probe on patient's head, and this computer is showing me in which direction I have to go to reach this hematoma. And this is during the surgery. I made a borehole and I'm putting the probe inside, and this green line, you can see the green line. The green line is pointing that you go towards this, so that I'll hit this target, which is the hematoma in the brain. So now we don't need to open the whole skull to remove the clots. We just put a needle, we flush it out and put a tube inside. You can see it beautifully. Now, next is surgery for refractory epilepsy. Now, this is the subject which is very close to my heart, probably because I've been thriving for this for last 6 to 7 years. Just a basic statistics, there are around 5 lakh candidates for a surgery in India, and around 400 to 500 surgeries are done every year. So you can imagine the burden of the disease in the society. When I say refractory epilepsy, means it covers only 5 to 7% of the total epileptics. I'm pretty sure every doctor sitting here must have treated more than hundreds of the patients of epilepsy. These are the patients who have been given multiple trials of anti-epileptic medication, still they keep continuous using, then those patients should be considered for surgical resection. And we are fortunate enough to have the first, again like navigation, this is the first epilepsy center in Gujarat, which is dedicated for surgical cases. And this is a video EEG lab. I'll show you a short video of the video EEG lab. So what is video EEG? આપણે જ્યારે ન્યુરો ફિઝિશિયન પાસે પેશન્ટ મોકલે કે સાયકાટ્રિસ્ટ પાસે EEG માટે, they take a video, they take a EEG of around 20 minutes, sometimes 10 minutes. It comes with some charts. It's a normal thing. Unfortunately, patient જે epileptics હોય, fluid epileptics, એમાં 1 out of 3 EEG is positive. So 66% of the patient can be missed out, even on a routine EEG, which is a good quality. So what we do in KD, this is a video EEG which is a 32 channel. So 16 number 32 channel, and even we are getting the 64 channel. So 64 probes on the head. Patient is admitted for 2 days, 3 days. So when I say 15 to 20 minutes monitoring versus 96 hours of monitoring, you can imagine the amount of data that we gather, and then this will tell us exactly the time when the seizures are starting. So you can see patient's hand is moving, patient's face is turning. At the same time, you can see the change in the EEG pattern. So this will tell us from which part of the brain, right, left, આગળથી પાછળથી, temporal, frontal, medial temporal, lateral temporal, ક્યાંથી epilepsy ચાલુ થાય છે ને, that it will take precisely, because we will monitor the epilepsy episode. We will not be doing simple EEG. We are monitoring the epilepsy episode. So why it is important? Patient epilepsy છે, we find small lesion in the brain, so it is possible that lesion is not causing the seizure. So we need to have triple diagnosis. So one is the clinical semiology, patient કયા ટાઈપની seizures આવે છે. Second is the radiology, MRI માં ક્યાં lesion છે, and third is the video EEG. Video EEG is confirmatory કે right temporal માં lesion દેખાય છે MRI માં, right temporal માંથી seizures ચાલુ થાય છે. Then we can afford to remove that part of the brain to make the patient seizure free. This is bit invasive recording. આપણે EEG ના leads લગાવીએ head ઉપર. Now this is opening the skull, craniotomy કરી, putting the grid inside, and then closing, and પછી EEG કરવાનો. So the patient comes out of the operation theatre like this. He comes out of the operation theatre with multiple wires, so that brain નું direct recording થાય. Endoscopy, I'll just mention about the shunt surgery, because being family practitioner, you must be seeing a lot of patients of hydrocephalus. This is very classical picture of a hydrocephalus with a huge head, setting sun sign, shiny skin. And the simplest procedure that we like, I mean, neurosurgery, the simplest of the procedure is VP shunt, where we put a burr hole on the head, we put an incision here and a shunt tube. But and this is how it looks. The cranial end, the lower end, and this shunt tube, and the CSF is coming. And that tube goes in the stomach. But unfortunately, this surgery carries so many problems in morbidity. Like blockage of the shunt because of the brain matter. The shunt can go anywhere in the body. The part that you imagine, it can go right in the head. The whole shunt is migrated in the head. The shunt can come out from the abdominal wound, from the oral cavity, from rectal, from penis, everywhere shunt can come out. It's a notorious thing. So again, neurosurgeon wanted to find an alternative to the shunt, to the hardware. So there is a simple procedure, which is like 15-20 minutes procedure, endoscopy, minimally invasive. So this is a pathology for hydrocephalus, where there is a compression of the aqueduct. The CSF doesn't flow beyond aqueduct to the fourth ventricle. The surgery is very simple. We put a burr hole, no hardware, no implants. The endoscope goes in. It's a 3.5 millimeter endoscope goes in, makes a small hole in the base of the brain, and the CSF pathway opens up. So this is the foramen of Monro. Everybody must have read this during MBBS. Foramen Monro and choroidal vessels, and this is the mammillary bodies. So just a short video how it works. So this is these are the mammillary bodies. These are our own surgeries at KD hospital. These are mammillary bodies. I'm putting a small forceps in front of the mammillary body and opening up the space. And once we have made the hole there, we expand the hole with the Fogarty catheter. This is a Fogarty catheter that is normally used by cardiac surgeon for embolectomy. Yeah, and you can see the flow of CSF, pulsatile flow of CSF. So this patient is cured of the problem without putting any extra hardware. You can see a small bore hole on the head, and the things are sorted. I'll skip this coiling and clipping part, because I'm more interested to show this last session of my talk, which is the tumor in the eloquent area. Like તમારી પાસે કોઈ બી પેશન્ટ આવે, like if I suggest કે ભાઈ તમારે ઓપરેશનની જરૂર છે, બ્રેન ટ્યુમર છે, the patient will come to a family physician કે જેની ઉપર એને મેક્સિમમ ભરોસો હોય. The common concern is કે સાહેબ અમારા પેલા પેશન્ટના સગાને ઓપરેશન કરાવ્યું હતું ને પછી લકવો પડી ગયો, પેલાને ઓપરેશન કર્યા પછી બોલતા બંધ થઈ ગયા, પેલાને ઓપરેશન કર્યા પછી જોતા બંધ થઈ ગયા. So those are the eloquent areas of the brain. Eloquent means brain નો દરેક part is important, but there are certain parts which are critical, which are unique, કે જેનું કોઈ alternative કોઈ replacement નથી. Like this is a speech area. I just showed you the video. The left side na inferior frontal lobe માં જે એરિયા હોય, it is a speech area, અને ત્યાં જો પ્રોબ્લેમ થાય તો પેશન્ટ will become aphasic. પેશન્ટ કોન્શિયસ હરતું ફરતું ખાતું પીતું પણ બોલશે નહીં, મૌની બાબા થઈ જશે. And this is a small area which is a motor strip. ત્યાં જો ડેમેજ થાય તો patient will be completely hemiplegic. Again, patient didn't talk. So these things are little apart, but they both are on the dominant hemisphere. So these are the cases where we can use that navigation technique or a computer guided surgery for a better outcome. So how we do it? Now, this is a surgery, very unique two cases I am going to show you. Awake craniotomy means patient is not under anesthesia. Patient, we give local anesthesia to skull, bone, dura, and we are talking to the patient continuously. The anesthetist is talking to the patient continuously, and we have got a special nurse who is trained for awake surgery. So we assess the patient preoperatively. Patient ne kahiye ke during surgery tame jagta haso. The reason is we want to check patient's power and speech during surgery. હું ઓપરેશન કરીને સરસ ટ્યુમર કાઢી કાઢું, પેશન્ટ પોસ્ટ ઓફ હેમિપ્લેજિક થઈ ગયું હોય, it doesn't make any sense to the patient family, right? So we need to continuously monitor the patient. So you can see
તમારું આખું નામ બોલો.
પેશન્ટના રાઈટ સાઈડ મોટર એરિયા ઉપર ટ્યુમર છે.
ક્યાં રહો છો તમે? હા, અને તાલુકો? હા, તમારે કેટલા
આ વાત ચાલે છે અને પેશન્ટનો પાવર બી ચેક થઈ રહ્યો છે. પેશન્ટ્સ પાવર ઇઝ બીંગ મોનિટર્ડ.
તમે પગના પંજા હલાવો.
She is moving the left leg now. So this is during surgery. એવું લાગે કે પેશન્ટનો પાવર ઓછો થાય તો we stop immediately. That we will not come to know if you are doing a conventional surgery with under general anesthesia. Now same is this, the lady that I showed you, tumor in the speech area. નાનકડું ટ્યુમર હતું right on the speech area. અને જો એ ટ્યુમર આપણે આખું કાઢી કાઢીએ without monitoring, the patient might end up with permanent speech loss. So you can see here, this is me operating, our colleague Dr. Usha. This is our operating microscope, a huge structure. And this is navigation system, and here is the monitor. Unfortunately, because of the quality of this, I cannot show you. But you can appreciate. I'm checking the tumor margins here. The tumor is out. We are checking that the tumor is completely out of this computer system. And that's a time when patient is actually.
અબ્દુલ્લા અચ્છા પાર્ટ્સ રિપીટ ક્વેશ્ચન્સ પૂછુંगी.
We are checking memory and speech during surgery.
हाँ हाँ, आपके हस्बैंड का नाम? यस, आपके डॉटर.
This patient wakes up from the operation theater conscious and talking.
Sir, please conclude lecture. Last 2 minutes remaining.
And there are few cases where the patient is not able to cooperate during surgery. There we have to use little more complex system, which is known as the intraoperative neuromonitoring, where because patient is very anxious, patient can have convulsion during surgery. So what we do is we put some electrodes on the head, keep continuous checking on the head and the face movement, and this is the whole system. When I'm doing a surgery, I put the electrode on patient's brain, stimulate the brain, check on this computer, and that will tell us કે આ પાર્ટ બ્રેનનો છે એ હાથને કંટ્રોલ કરે છે, આ પાર્ટ બ્રેનનો છે પગને કંટ્રોલ કરે છે, so that you can take out the tumor safely without damaging the patient. So just to conclude, evolution for better tomorrow. Like everybody in every field should evolve and gaining experience from our own mistakes. અમારા ટીચર શીખવાડતા હતા કે લર્ન ફ્રોમ મિસ્ટેક્સ, બટ એવરી ટાઈમ ઇટ ઇઝ નોટ નેસેસરી ટુ મેક ઓન મિસ્ટેક. તમે કોઈની ભૂલમાંથી બી શીખી શકો. ન્યૂ એન્ડ મિનિમલિઝમ ટેકનિક ફોર એવરીથિંગ, મેડિસિન, સર્જરી, લેપ્રોસ્કોપી, એન્ડોસ્કોપી, એવરીથિંગ. our own morbidity. We have regular audit meetings at KD hospital which audits our mortality, morbidity, કેમ થયું, હવે ભવિષ્યમાં કેમ ના થાય એના માટે શું કરવું, ICU માં complication થયું. So we need to learn from that. Incorporate young people. Like we started our practice in 2008. Then 2014 new person joined, 2017, 19, and recently we had a guy from AFMC Pune. So incorporating new people will get new ideas, new energy, and new enthusiasm. And balancing greed versus need. મારે આ બી ઓપરેટ કરવું છે, મારે આ બી ઓપરેટ કરવું છે. It is not possible for one surgeon to do everything. So we have to balance those things. And optimal counseling, because the cases that I showed you, really high risk cases, કે patient operation પછી લકવો થઈ ગયો, કે speech જતી રહી. We need to have a detailed, thorough counseling of the patient, family, audio, video, everything detailing. Okay, in spite of all this, there is a small possibility that patient might end up in a complication. And outcome-based treatment. So the last slide. Once upon a time, before like 15-20 years, તમે બધા senior બેઠા છો એટલે ત્યારે કે એક ડોક્ટરને બધું આવડે. You know, he can do everything. But now it is not possible. We need a specialist for everything. Like પહેલા હતું orthopedic surgeon, પછી upper limb surgeon, lower limb surgeon, hand surgeon, finger surgeon. So it's a specialty. It's not something fancy, but this is the need of our. And keeping in that mind, we are a team of 6 senior neurosurgeons, and this Dr. Love Patel, who has recently joined us. So now we are a team of 7 neurosurgeons working together as a team, and everybody has got their own specialty. I'm focusing more on cerebrovascular and epilepsy. Dr. Sandeep Mode છે એ coiling and clipping aneurysm નું coiling કરતા હોય છે. Dr. Rushabh Parkinsonism માટે DBS surgery આપણે ચાલુ કરી રહ્યા છે. And that's how we work at KD Hospital as a team of neurosurgeons. Thank you.
Thank you very much, sir, for giving nice lecture on latest approach in neurosurgery. I request Dr. Suchi Smita to give memento to Dr. Gopal, sir.
Now I request Dr. Manish Khaitan to deliver the second speech.
This is going to be very interesting lecture. Topic will be what BIM is required in thoracic surgery. Sir, your session will be for 15 minutes.
Yes, sir. I'll try to be in time.
standard BMI sheet and how to read a BMI sheet. There are some machines which work on bioimpedance. તમે એના ઉપર ઉભા કરશો તો એક BMI નું આખું ચાર્ટ નીકળશે અને તમે ચાર્ટને જોવા જશો તો it gives you weight, it gives you weight, it gives you height. The weight is 59.1 and it gives you muscle mass also. Here there is a muscle mass. It gives you water mass also. It gives you percentage body fat also, which is normal. And if you go by serial composition, suppose this patient you started some management of treatment, this is what the chart will come as far as weight, skeletal muscle mass and body fat percentage is concerned. So in one, suppose you have started treating the patient for a month or for 6 months, you can track his complete progress with this BMI chart. This is the most accurate system which is available with us to assess this patient as far as BMI is concerned. So how you read it, this is the total body weight, then there is the body mass index as we have talked, percentage body fat, total body water, what is the basic basal metabolic rate. Suppose you have given him some food or some exercise to increase his BMR, you can check the BMR report in the next visit when the patient comes. What is the visceral fat level? As we all know, visceral fat is responsible for all the metabolic disease that we have. You can check the skeletal muscle mass, bone mineral content, protein mass and segmental lean and fat analysis, which goes to both limbs separately, your trunk separately, chest separately and both hands separately. So this is the Aussie guidelines for BMI and bariatric surgery, that is Obesity Surgery Society of India. That is BMI more than 37.5 without presence of any obesity related comorbidities, or BMI more than 32.5 with the presence of type 2 diabetes mellitus or any obesity related comorbidities like hypertension, hypercholesteremia, knee pain, back pain, depression, everything is there. This patient should be motivated to lose weight and commitment for a long-term follow-up, and that's why we have got a great team, because we provide them free follow-up for their life. We don't charge them, because once we don't charge them, they are motivated to come to us for the follow-up. And patients should have attempted conservative method of weight loss and failed diet, exercise, and they have failed it multiple times or at least a single time, or there is a medical condition, એટલું severe knee pain છે કે exercise થઈ જ નહીં શકે, then we can think that that patient can be subjected to surgery immediately. The age should be between 18 to 65. Beyond 65, you have to assess the condition and then only ask the patient to go for surgery, and below 18, again you have to assess the situation and then you have to go for surgery. You have to put a team of pediatricians, endocrinologists, and then certify that this patient is suffering, for example, with a severe sleep apnea and may die within some times. In one case, at age of 6 years of boy was operated by us because he was having a weight of 90 kilos and was suffering from severe sleep apnea, and his PCO2 levels were with BiPAP were maintained at around about 60 to 65. So is it a correct criteria to measure? I would not go in that controversy, but this is the easiest criteria to measure. There can be different measurements, there can be different ideas in the audience also. Okay, we have to go by the measure or the chest hip, waist hip ratio, this and that. But this is the easiest thing which you can do. You can just ask your subordinate or your nurse or your compounder to do it for you. He will just give you weight and height. Go on your calculator, put the things there, weight divided by height in meters square, and you get a BMI. So there can be different criteria, but any criteria has not been able to replace the BMI as far as now it is concerned. Even the international body, whatever modification they are making in the criteria of changing the BMI, they are working on BMI only, not on anything else. So what are the other criteria? Can be waist circumference, waist to hip ratios, infold thickness, bioelectrical impedance, MRI, and DEXA scan. Why BMI has not been replaced and still stands the best criteria to measure obesity? As I told you, this is easiest. In everything else, there can be either margin of error, or they are very costly machines to be installed and they are not commonly available. The interpretation is difficult, so still we think
This is the best criteria to measure a patient's obesity factor. It is class 1, class 2, class 3 associated with comorbidities or not. And as a family physician, you can just keep in your mind, okay, it is 32.5 with diabetes, he qualifies. If it is 37.5 without any comorbidities, it qualifies. Medically, at least you are not wrong as far as you are advising the patient bariatric surgery if he requires so, or if he or she asks for that. So these are the guidelines. They are Western guidelines, and they are different guidelines which has come. So usually the Western guideline is about BMI 40 and 35, 40 without comorbidity and 35 is without comorbidity. Where Australia and New Zealand is as good as Western guidelines. ASMB's American Society has their own guidelines because severe morbid obesity is there, which is again as like Western guidelines, but below BMI 30 with uncontrolled diabetes, they have started offering surgery because that has been certified by American Diabetic Association. Then there are IFSO guidelines, which we all follow. Again, more than 40 and more than 35 should be considered for surgery. Then, as I told you, Asians are different from Westerns. We have got more fat mass. We have got more fat mass and less skeletal mass. So we have got other criteria. So with BMI more than 35 with diabetes, it is an accepted option to go for surgery. BMI 30 to 35 with inadequately controlled diabetes, then you can ask the patient to go for surgery. In Diabetic Surgery Summit, which was held in 2007 in India, New Delhi, it was considered that BMI between 30 to 35 can be considered for metabolic surgery to correct his diabetes. And then again there was the Asian Diabetes Surgery Summit where BMI more than 37 is without comorbidities, and with comorbidity it was BMI more than 27 without many comorbidities may be considered for surgery if the diabetes is uncontrolled. And if you are talking about diabetes is uncontrolled, that means the HbA1c is more than 7.5 with all possible treatments and lifestyle modification which the patient is taking. And if the HbA1 is controlled by till 7.5 and the BMI is more than 32, you can consider the patient for surgery. So this is the major updates in NIH guidelines. NIH is a guideline which is an American institution, and they form guidelines for surgery in America. In India, we don't have any governing body which is instituted by the government of India to form such guidelines. So they have formed guidelines for their own patients and go to number 3. That is, BMI threshold should be adjusted in the Asian population, such as a BMI of more than 25 suggests clinical obesity, and individual with BMI of more than 27.5 can be offered metabolic bariatric surgery. Again, metabolic bariatric surgery, MBS stands for metabolic bariatric surgery. That means the patient is overweight with diabetes, which is uncontrolled with all treatment with what you have offered to the patient. Then, as I have told you, the BMI, as you all know now, bariatric surgery has been included in this cashless treatment or Mediclaim. So the Mediclaim company or the IRDA, which governs the Mediclaim, has come with their own guidelines, which may not be that perfect, but at least it has started. The surgery has to be conducted upon advice to a doctor. So my suggestion to you is, once you advise a patient for bariatric surgery, kindly put your notes in your first consultation. With the patient, I am seeing the patient since last so many years. The patient is suffering from obesity. He has tried diet and exercise. He is not able to lose a weight. Now we advise him to undergo bariatric surgery. This letter stands so much of value and so much of weight for us. If we put that letter only to the Mediclaim company, mostly the cashless claim is approved. So surgery procedures should be conducted supported by clinical protocols. We have got a complete set of clinical protocols at our place. The member has to be more than 18 years. The BMI here is like Western. It is equal to 40 or more than 35. And in 35, the comorbidities they have included, for your just knowledge, is obesity-related cardiomyopathy, coronary artery disease, severe sleep apnea, uncontrolled type 2 diabetes mellitus, which is not enough. We have made our own representation to include more comorbidities and make it more simpler as far as international guidelines is concerned. It should be in conjunction with that, but I think it is not going to take a lot of time. So I have not much to say in BMI. Thank you very much.
Thank you very much for giving a nice lecture, sir. Now I request Dr. Dilip Bhutari for giving a memento for Dr. Manish Khetan. Very interesting and useful in our day-to-day practice in the for the family physicians. The session will be for 15 minutes, sir.
At the outset, let me thank the organizing committee to give this opportunity. And I'm delighted to see that almost the entire hall is full, even on Sunday. Many a times, we don't get delegates for even our neurology conferences. So I have been given the topic of stroke protocol, and of course I'll be talking on the acute ischemic stroke and not on the hemorrhagic stroke, and the management principles which have evolved in last 2.5 decades. I would present in the protocol-based management that we do at our hospital. Now, we know that the ischemic stroke either is due to the clot coming either from the one of the major carotid arteries or the aorta or directly from the heart. The major pathophysiology is the decreased blood flow, giving rise to a cascade of metabolic changes resulting in ischemia, which gives rise to neuronal damage and causing neurological deficits. And our aim is to prevent these neurological deficits and to maintain the perfusion in the hypoperfused areas to save it from getting further damaged. My colleague Dr. Gopal highlighted so many advances in the neurosurgery over the last few decades. Still, I find that there is a lot of nihilism about the neurological diseases. In fact, when I started practicing in 2005, when I was attached to one of the medical colleges, there was a talk that only 4 or 5 medicines are useful in neurology, rest all is just humbug. So all this kind of nihilistic attitude has caused a lot of hurdles in the advancement of therapy. And this not only comes from the non-neurologists, even the neurologists also, they have shown a lot of hesitancy in adopting new therapies which are actually effective, they are proven. So just like that, in stroke also, we have a lot of advances in the last 2.5 decades. And but to apply these advances, we need to go in a systematic way. We need to follow certain protocol. If we violate લક્ષ્મણ રેખા આપણે ઓળંગીએ તો આપણને તકલીફ થાય. So we should not violate the protocol. So there are certain problems in this. Out of these problems, I would highlight the first four problems, that is regarding the diagnosis, delayed referral, choice of neuroimaging modality, and the decision on further thrombolytic therapy. So the diagnosis is missed at all levels, and being in a forum of family physicians, it is very easy to pick up a patient who develops hemiplegia or aphasia, dysarthria, and it is very easy to say that they have stroke. But there are certain other atypical presentations, like in some cases, after developing a transient hemiparesis or transient dysarthria, patient improves, but still he may be harboring a major vessel occlusion, and like we see in the cases of basal artery occlusion. So after few minutes or few hours, they further deteriorated and they develop a full-blown stroke. Just like that, we also see atypical presentations like altered mental status, nausea, vomiting, dizziness, etc. So these could be the symptoms of posterior circulation stroke, and we should be alert about this. Now comes the most important thing. If any of your old patients, their relatives, your relatives, they come to you with acute neurological deficit, what should be done? In those old days of nihilism, we used to admit them, and they used to sometimes wait in the queue for CT scan, or they used to waste time for several other. We have also seen B12 therapy given to such patients. So all this delay would ultimately result in poor outcome. The patients should be referred to a stroke-ready hospital, and by stroke-ready hospital I mean that the hospital has all the infrastructure in place regarding the stroke management. That means the acute stroke team, which Dr. Gopal has already highlighted, which follows the treatment according to a protocol. There is a round-the-clock availability of imaging, lab testing, and that too, the report should be available as soon as possible. There should be 24/7 access to stroke expertise. That means not only the imaging, even the cath lab in cases where we plan endovascular therapy. And the goal should be to give this therapy achieving a door to needle time of less than 60 minutes within the window period of 4.5 hours for the intravenous and 6 hours for the endovascular therapy. Now, let us see how this would be done. So, just 1.5 months back, one gentleman, 77-year-old, presented with acute left hemiparesis with difficulty in speaking. He developed this at 5 a.m. Somewhere near Gandhinagar, Adalaj. He already had complete heart block with insertion of permanent pacemaker. He was drowsy, had dysarthria, left hemiparesis with facial weakness. It was good for the patient that the doctors at the local center, they immediately referred the patient to us. Now this patient arrived at around 10 past 6 around, that means about 1 hour and 10 minutes after the onset. According to protocol, of course, we would be measuring the blood glucose, vital parameters, oxygen, ECG, everything. Along with that, we would administer the National Institute of Health stroke scale, and our doctors in ER are trained to administer this. This gives us a quantitative assessment of the neurological deficit. Our patient had the NIH stroke scale score of around 16, and that means that he was having a moderate to severe stroke and likely to suffer from a severe neurological deficit if not intervened. Now, what modality of imaging you would select? I would just like to ask the audience, what CT scan should be done, MRI should be done, what should be done? Yes, absolutely easiest things are done quick, easiest and cheapest thing should be done first, which gives us a correct result. The goal of imaging is to exclude hemorrhage, presence of any intravascular thrombus, and also give us some idea about the mechanism of stroke and the amount of area involved. This is very well achieved by plain CT scan. Along with that, if we do CT angiogram, we can demonstrate the major vessel occlusion. This, in our protocol, we do the creatinine and then we do the CT angiogram. So sometimes we can start administering the IV thrombolytic therapy if patient is a candidate. CT perfusion is an advanced imaging technique. We don't have that, but that is useful to assess the penumbra, which is the viable tissue which is not yet infarcted. So in our case, the first slide, the scan was, as we can see here, it was done at around 6:40 a.m. There is a small area of hypodensity in the insular area, and that means patient has a developing stroke, and there is a scoring to assess this. The total number of hypodense areas in the image, the maximum is 10, the minimum is 0. Now, if the patient has a severe deficit and the aspect score is around, say, 0, 1 or 2, that means he is a very good candidate for the intervention because he might have a good outcome. Whereas if the score is around, say, 8, 9, 10, then still he will be a candidate, but outcome may not be as good as we maybe explain this to the relatives. That is a very important finding. Now, along with that, in the plain CT, we can see this thrombus also sometimes, which is called hyperdense MCA. The CT angiogram of our patient showed this occlusion at the level of MCA, the M2 segment of MCA. We can see this here in the first slide. So he was definitely candidate, and we proceeded with the further treatment. Just to mention that since we have MRI in place, and many times there is confusion regarding the diagnosis, and if we can get the MRI quickly, that is also a very useful technique. And in our cases, we apply this when we can get MRI within, say, about 20-30 minutes. Meanwhile, we await the investigations, and this should include the diffusion weighted. And MRI becomes particularly useful in our setup when patient develops a stroke on waking up. Now, our case also had a similar presentation, but when patient comes, suppose at 4 o'clock, 5 o'clock, 6 o'clock, we don't know the exact time of onset. So in that case, if diffusion is showing hyperacute infarct, but the flare image is negative, we can say that this could be a potential candidate for thrombolytic therapy. So we can proceed with the CT scan. In our protocol, MRI, CT scan, we decide on the basis of our presentation of the patient and the associated factors, like in this case PPI was there, so we cannot do MRI. So of course, obviously CT scan was the choice. While awaiting further results of angiogram, if patient fulfills the criteria for giving thrombolytic therapy, we can start with the intravenous therapy, about which I will discuss just now. In the management, there are two important things. One is reperfusion and another is the prevention and treatment of complications. Neuroprotective therapies are all just what I can say, they are just gimmicks. We don't stress much upon them. Reperfusion can be achieved with intravenous fibrinolysis with the use of recombinant tissue plasminogen activator or tenecteplase. Intraarterial fibrinolysis also is done, but not much in use nowadays. In appropriate candidates, we can proceed for the intraarterial mechanical thrombectomy with the help of interventional neurologist or neurosurgeon. So who are the likely candidates? Our patient presented within the window period of 4.5 hours. He did not have any hemorrhage on the CT scan. There is a list of contraindication that we have to rule out, and this is assessed in the emergency room. This should not be given in the pediatric age group. In elderly, age 8, more than 80, we can still use it with caution. We have given in patients who are 80 to 83, but the risk of bleed is slightly more. There is a list of contraindication, as I said. The most important thing is that if there is hypo or hyperglycemia, that should be corrected first, and blood pressure should be kept below 185 by 110, preferably by IV labetalol and not oral antihypertensives. So overall, the benefit is more than risk if we do not violate protocol. That means we give this within window period, keeping in mind all the contraindications. So if we administer this to 3 or 4 patients, out of this, at least one would achieve functional independence at 3 months, and the risk of symptomatic bleed is much less. In fact, it is around 6 to 7%, but in our practice, we have seen it even lesser. So, who are the candidates for acute endovascular therapy? Now, I said that we do the CT angiogram, and if that is showing major vessel occlusion, it is possible that intravenous therapy may not achieve recanalization in all patients. So, if the patient has a significant NIH stroke scale of more than 6, if we can ready the catheter within less than 6 hours of window period, and if we can demonstrate the presence of a proximal intracranial artery occlusion, these patients can be benefited with mechanical thrombectomy. And here also we can use the IV therapy before we plan the intra-arterial therapy. So we can combine the two, and that can also give good outcomes. Now, just to highlight the role of heparin. Heparin is of no use in the acute setting. In fact, when the patient comes to your clinic, heparin should not be administered if acute ischemic stroke is suspected, because in that case, we may not be able to give thrombolysis. BP should not be overtreated. We should not cause hypotension. Oral nifedipine also has no role. And just to see what happened to our patient, following thrombolysis, we did post-thrombolysis scan 24 hours later, and this showed a small area of hypodensity with changes of reperfusion, which are seen here in the second image. Patient was overall discharged in good ambulatory state and did not have a significant residual deficit at 1 month of follow-up. Just one more slide, and then I will conclude. Since this is a forum of family physicians, do you know who is this? He is not a doctor. He is an actor who played the role of Dr. Clarkson in one of the popular web series, Downton Abbey. And this is the role played by him is that of an ideal family physician, and it would really interest any person belonging to medical fraternity how he managed the problems of the family, medical problems, as well as the social problems. But when he tried to enter into a relationship, he made a mistake. Of course, we don't do that. Thank you.
Thank you very much, sir, for giving a nice lecture. I request Dr. Suchismita, sir, please, to give a memento to Dr. Ruchil Behavior. I request last lecture of the session, Dr. Vinod Shah. Please welcome. Topic is an important law for the family physicians. It is very important lecture and subject because other than the medical knowledge, it is very important while we are doing the practice. Sir, session will be for 15 minutes, please.
Thank you. Thank you, Chair, and thank you, organizing committee, for giving me the opportunity to express my views on the basic laws every family physician should be aware of. Friends, we know that the practice in medicine is regulated by certain laid out legislatures that refers to laws that are passed by either central government or state government to take care of particular entities. Numerous aspects of medical practice are bounded by regulations, and there are as many as 72 laws practicing doctors have to follow. But here, within 15 minutes, I am going to enlighten on very few important laws. They are Biomedical Waste Management, Gujarat Chemical Establishment Act, Communicable Notifying Bans, Gujarat Prevention and Life Safety Act, Epidemic Disease Act, Consumer Protection Act, 1986, and its amendment on December 2019, the Healthcare Violence, the legal provision regarding death certificate, and National Medical Commission Act, what every family physician should know. Are doctors included in biomedical waste? It is very important question pertaining to us. According to rules, it's yes. As per biomedical waste management rule, every person who is involved in the generation, collection, storage, transportation, reception, recycling, and disposal is required to have authorization. All clinics must be registered with Gujarat Pollution Control Board in case of Gujarat for BMW generation, and family physician who runs OPD, no bed in indoor have to register for one time only. We know the various steps, there are segregation, collection and storage, transportation and treatment of the material. And definitely one most important thing for the family physician to auto-disable the syringes, to put the cut syringes in the infected part and the sharps in the other bit. And what is the non-compliance? What is the penalty? Imprisonment of 5 years or fine of rupees 1 lakh or both. Most important law, Gujarat Chemical Establishment Registration and Regulation Act 2021, published in the Gazette on 13 May 2021, known as Gujarat Act number 18 of 2021. Why Clinical Establishment Act apply to us? The purpose of the Act is to prescribe the minimum standard of facilities and services provided by the clinical establishment so that mandate of Article 47 of the Constitution for improvement of the public health may be achieved. Highlights of the facts are there, but few salient features. Registration for clinical establishment is a must as per this Act, whether it is existing or it will be new, to comply with mentioned standard of facilities and services, the requirement of the staff as may be prescribed, provision of maintenance of the record and reporting as per the laws, mandatory display of the degree and registration of the certificate in the clinic so that whoever like to see can read it. And in case of change of location or not on ceasing of function, certificate shall be surrendered. Consulting room, they have given the specification for what, list of equipment are there, dispensing of the medicine from clinic by qualified staff under the direct supervision of the doctor for the facility of the waste disposal, to segregate the waste, dressing material needed as per the Government of India and GPCB norms. Records, medical case records have been maintained for a period not less than 10 years. Staff, doctor and certified paramedical staff. Now what is the penalties? Non-compliance, whoever contravening of the provision of the above act, for the first offense up to 10,000 rupees, for the second offense up to 50,000 rupees, and for subsequent may extend up to 1 lakh rupees. And what is the penalties for the clinic running without obtaining the permission, that is registration? First contravention, penalty up to 25,000, second 50,000, and subsequent up to 1 lakh rupees. Third is important for the family physician law, Communicable Notifying Disease Act. A notified disease is any disease that is required by law to be reported to government authorities, because the collection of information allows the authorities to monitor the disease and provides early warning of possible outbreaks. This act provides for policies and prescribing procedures on surveillance and response to notifiable diseases, epidemics and health events of the public health concern. Section 13 of the Act contains this provision of notifiable diseases. Few acts to mention are Food Safety and Standard Act, the Lepers Act, the Epidemic Disease Act 1897, National AIDS Control and Prevention Policy, Epidemic Disease Act, and some example are cholera, hepatitis, dengue, malaria, tuberculosis, and measles. Penalties, a jail term up to 6 months or a fine or a board as per IPC 189, 269 and 270, and definitely 269 and 270 it is recently included in tuberculosis also. Even chemists can't sell the tuberculosis medicine from OTC counter. Fourth one is Gujarat Fire Prevention and Life Safety Measure. This fire extinguisher photo is of my clinic. Doctors have to apply to Form 15, apply to grant fire safety certificate for clinics having height more than 50 meters and surface area ground more than 500 square meter. A fire safety rule in say fire extinguisher, smoke alarm and sprinkler. Punishment, imprisonment of 5 years, penalty or fine or rupees 1 lakh or both. Epidemic Disease Act 1897. Any person disobeying any regulation order made by the collector, municipal commissioner or district health officer shall be deemed to have committed an offense punishable under section 180 of Indian Penal Code. Any person committing an act of violence, it is added by court after corona, against healthcare worker or causes grievous hurt as defined in section 320 of IPC. We see number of attack on the healthcare on after corona. Offense. Now friends, very important laws. Consumer Protection Act 1986 and its amendment in 2019. We all should be aware about this because no other service provider have faced number of cases filed against them in comparison with what the number of cases filed against doctor after provision of CPA. Again, after 2019, the limit at every state they have raised. In the district commission, initially it was up to 10 lakhs, now it is raised up to 1 crore. State commission 1 crore to 10 crore, and national commission above 10 crore. Penalty is given right to file complaint against doctor from his resident. I have treated the patient in Ahmedabad, residing at Gauhati. So he can launch the complaint against me from Gauhati. I have to go there. And to answer in that court, really cumbersome for doctor. Unfair tax practice, it will not issue the receipt to maintain the secrecy. Mediation sale is created after 2019 Act. So one can go settlement outside the court, but the worry for the medical fraternity is eligibility and quality of mediators not mentioned. Initially at the district forum, retired district judge, at the High Court level, retired High Court judge, and Supreme Court level, retired Supreme Court judge were the chairman of the commission. Now they have removed that clause. An appeal can be filed after depositing 50% of the commendation claim, and e-filing of the complaint is now permitted. So, what is the penalty? Imprisonment of 3 years with fine not less 25,000 to 1 lakh rupees. This is the Prohibition of Violence and Damage to Property Act. Day before yesterday, we came to know regarding the incidents happened in the Yavatmal, Maharashtra. The doctors have been attacked by the knife. Violence, very clearly here they will define. Violence means harm, hurt, previous hurt or danger to life of a healthcare service personnel in clinical establishment or otherwise obstruction to a healthcare personnel in discharge of his duty or loss or a damage to any property or documentation. I have attended this case along with Dr. Chawda, Dr. Gatiwala, and Dr. Bhuji Modi. We went to Dhule to see this patient. So we can see also the damage to property. Assaulting a doctor is a crime. Up to 5 years, 6 months to 5 years, and 50,000 to 5 lakhs rupees. And in previous are 3 years to 10 years, and 2 lakhs to 10 lakhs rupees. And amount twice the amount of fair market value of the damaged property, the loss causes here may be decided by the court. Another very important point we are coming and discussing, legal provision regarding issuance of the cause of death certificate by family physician. Friends, what do you reissue? Reissue death certificate? No. A big no. Reissue a medical certificate of cause of death, that is MCCD, not death certificate. Then who issue the death certificate? As per 1969, birth and death documentation, it is a municipal authority who is going to supply, correct, issue the death certificate. Legal provision for MCCD, it is a duty of doctor. We do have a legal implication. Take due precaution in filling MCCD. Use Aadhaar card for correct name, age, sex, and address. Never issue a duplicate certificate after few days. Never charge a fee for an issue of MCCD. Who will submit the MCCD again as per the Birth and Death Registration Act 1969? It is the registered medical practitioner responsibility to forward the MCCD to the registered authority. Certain grounds for death certificate, never issue a certificate without examining the dead body personally, that is from the front side, from the back side, as well as the skull. Whenever the patient, the injured patient brought dead, don't issue. Crime has already been registered by police. Police has already been informed. The cause of death is not known to you. Whenever the brought dead young man, female, pregnant lady, child, and there are cases of homicide, suicide, poisoning, and accident, never give the certificate. It is an important legal document from the point of view of deceased person relative. So write legibly in capital letters, avoid abbreviations, use other cards, put initials, alteration, keep duplicate copy, and never charge a fee for issuance of MCCD, even fees are due. NMC, National Medical Commission and Registered Medical Practitioner Regulation 2022, Medical Code of Ethics. Friends, this discussion going in the whole deep, so in short only in 30 seconds, I am going to just discuss. There is a restriction on commission, self-promotion and publicity is not allowed, compulsory we have to maintain the records, professional consult, and 9-point continuing medical education, 30 credit hours every year. Government is going to bring this thing, and license to practice should be renewed every after 5 years.
So requested to conclude in 2 minutes.
Yes, sir, only one. So certain do's and don'ts to avoid the medical legal complication. Always mention the name, qualification with NMC registration number. Always record the date and time of consultation, because in family practice, in major setup we examine the patient in morning as well as in the evening session. Record the age, sex and weight of the patient, and findings should be recorded. Make a note of the refusal, because whenever we request the patient to go for ECG, in case of test, patient didn't go on and his relative an attack on. Sir, when you come to know the patient is having heart attack, why you have not sent to him? Mention in your case paper that I have asked the patient to go for ECG. The hospital, lab test, write about the drug allergy in bold letters in our case paper, write prescription clearly in generic name, mentioning dose, duration, and instruction. Keep updating your knowledge by attending Natcon 23 and other conference and practicing evidence-based medicine. Advise hospitalization for critical patient. Don't hesitate to discuss with our colleague whenever required. Discuss clearly with patient in detail about health report. Don't examine the patient when you are sick or under alcohol effect. Don't too close with the patient. Never, never. Don't criticize your colleagues. Don't examine the female patient when you are alert. A big thank you. Thank you very much.
Thank you, Vinay. Thank you very good. You are very good lecturers. I would request Dr. Murray to please take the mic.
Dr. Vinod Shah to give the moment for our this session's chairperson, Dr. Suchi Smita Pathak. Our second session is being completed. I request Dr. Gopal Shah to come on stage and give a memento to our second chairperson, Dr. Dilip Kothari. Thank you for cooperation for the second session. Please don't leave hall because now the very exciting session of the quiz is going to start. And there is a very fabulous and very precious and very good gift for the quiz. As yesterday, few of our delegates must have attended this our Hall B program. The system and the whole procedure I tell you must be knowing. All the delegates and participants are supposed to log in from their internet browser, that is Chrome or any other either Apple or Android phone. And it's www.afpa.co.in/hall-b. After logging this web address, you will be getting a question with multiple choice answer. There will be 4 answers. You have to select one and submit. The earliest person who will submit the correct answer, the correct answer and name of the person will be recorded in the system, and we will be declaring as a winner. And he will be or she will be getting a very fabulous gift and prize for that. Time already has been started. It is total time is 2 minutes. 1 minute already has been lost. Last 1 minute is remaining. Because of the internet problems of the different network and different mobiles, it might be possible if the delegates members might not be able to open the link. If you are opening the first time, you are supposed to fill up the first name, last name and mobile number, so we can come to know when you will submit your answer in our system. I am giving 1 more minute if somebody is facing problem. Question already has been released. Verbally, orally question not will be declared because as a organizer, even I am not informed the question because I am not supposed to know the question and I am not supposed to know the answer. Let the answer see of our delegates. Thereafter, I can take your answer also. Last 15 seconds. First correct answer we have received in the system is Lapsiwala. More than 10 correct answers we have received. But as I told, first answer we receive will be considered and declared as a winner. Now I'm starting the next session. I invite as a chairperson Dr. Ramesh Jain from Surat. I invite Dr. Vikul Shah from Baroda, and I request Dr. Hemant Shah as a rapporteur of this session. Please come on stage as early as possible. In this session, again, we are having 4 lectures. Each lecture is given 15 minutes. First lecture by the Dr. Kamal Gopnani. I invite and welcome Dr. Kamal Gopnani. The topic is kidney transplant indication, contraindication, and post-transplant care. Kindly note, sir, this session will be strictly for 15 minutes, please.
Good morning to the respected seniors and dear colleagues. At the outset, I would like to thank the organizers for giving me this opportunity. So today I would be discussing about renal transplantation. So as we all know, for patients with end-stage kidney disease, what are the options? So we have only 2 options, either dialysis or kidney transplantation. So if you look at the 2 options, the dialysis in red, and if you see the 10-year survival, it is around, which is less than 30%, while in kidney transplantation, if you see the 10-year survival is very good, it is around 70 to 80%. So if we look at the 2 options, like kidney transplantation versus dialysis, once again you can see here in the yellow, 8 years kidney survival for a patient with transplant is more than 80%, while on dialysis it is around 40%. So definitely kidney transplant is the best treatment for option for patients with end-stage kidney disease. So indications for kidney transplantations, when the patients have GFR less than 30, that is the time when patient needs to be counseled about kidney transplantation. And potential candidate can be evaluated at least 6 to 12 months before the initiation of dialysis. So they have enough time for deciding for kidney transplantation. Now a word about preemptive transplantation. So what is preemptive transplantation? So preemptive is when in adults when the GFR is less than 10, and in pediatrics when the GFR is less than 15, in children when the PFR is less than 15, they can undergo transplantation without initiating on dialysis. So chronic kidney disease stage 5 can directly go for transplantation. Why? Because the outcomes are better than compared to being on dialysis and then doing a transplantation. Now, what are the contraindications? So, contraindications are for only kidney transplantation, like kidney alone. If the patient is having multiple myeloma or amyloidosis, decompensated cirrhosis. Now, recently we did a combined liver and kidney transplantation in a patient who was having cirrhosis of liver and end-stage kidney disease. So, this is a contraindication for only kidney transplantation, but it's not a contraindication for a combined transplantation. Then, severe irreversible airway disease, any cardiac disease or neurodegenerative disease, which are severe. Now, when do we need to delay the transplantation? So, we need to delay the transplantation if there is like a patient is in substance abuse, or patient is having active infection, or patient is having active malignancy, or patient is having active cardiac symptomatic disease, and which after probably if you have an acute MI, probably after 3 months we can undergo a kidney transplantation, or a recent stroke like within 3 months, or this is a symptomatic peptic ulcer disease or severe hyperparathyroidism. These are the things when we need to delay the kidney transplantation. This is our team of transplant surgeons and us.
So I would like to describe one case, a 25-year-old female who presented to us in January 2022 with history of dyspnea, edema, nausea, all uremic symptoms, a creatinine of 9 and urine albumin was +2. On ultrasound, both the kidneys were small. So in an adult, a kidney size of 9 centimeter is normal. A kidney size less than 9 centimeter is a small size kidneys. We investigated her and we explained her about the renal replacement therapy. So either dialysis or kidney transplantation. And she came back after a month with mother as a donor. We initiated the dialysis and we did the kidney transplantation. So we can see here the warm ischemia time was 5 minutes, anastomotic time was 30 minutes, and after anastomosis the kidney became pink and turgid and made around 1000 ml of urine in an hour, and we replaced with normal saline, half normal saline and bringers lactate, and we did the electrolytes every 6 hourly and the tacrolimus level on day 3 and day 7, and replaced all the electrolytes. On post-op day 1, our creatinine came down to 1. On post-op day 4, creatinine was 0.7. She made around 9 liters of urine and she was discharged on day 10 with a creatinine of 0.9. So this is the patient and the donor. So now the objective is immediate care and long-term care. So immediate care is a 10-day hospital care and the long-term care is long-term follow-up after discharge from the hospital. So immediate care involves ICU care, fluid electrolyte management, immunosuppression, antibiotics and monitoring. This is our operation theatre. This is our ICU where we keep the patients after transplantation. And ICU care involves fluid and electrolyte management. We replace with half normal saline because the half normal saline is the concentration of the urine, the same concentration. And we monitor electrolytes 6 hourly, and we monitor graph Doppler on day 2 and tacrolimus level on day 3 and day 7. This is a graph Doppler which shows a good perfusion in the kidney. So immunosuppressive regime involves an induction immunosuppression in form of interleukin-2 receptor blocker, methylprednisone, steroids, 500 milligram daily for 3 days, and tacrolimus and mycophenolate mofetil. We give prophylaxis for CMV and PCP for 6 to 9 months to prevent infection after transplantation. So this is how we categorize the patients into low risk group and high risk group. If the patient is like say HLA matched, then he is in a low risk group, versus if he is a HLA mismatched, then probably he is in a high risk group. These are the induction agents, either depleting or non-depleting. So thymoglobulin or IL-2 blockers. Maintenance immunosuppression, we usually give triple immunosuppression, steroids, mycophenolate mofetil, and and tacrolimus. Sorry. This is the figure which shows the mechanism of action of various immunosuppressive agents where they act on the different phases of the cell cycle. So if you look at the outcomes, so if you see in the green bar the outcomes at 1 year and the rejection rates at 1 year. So now with the modern immunosuppression, we have come down with the rejection to less than 8% at 1 year, and the outcomes are like 96% at 1 year. So the success rate of kidney transplant is more than 96%. And if you see the causes of acute kidney injury in post-transplantation period, either it can be surgical or it can be acute tubular necrosis because of hypertension, or it can be because of blood toxicity or rejection. Now it is most important to achieve the balance between rejection and infection. If you give too much of immunosuppression, we can end up with infections. So this is the new timeline of infection, where in the first month after transplantation, you can see what we commonly see is the wound infection, bacterial pneumonia and urinary tract infection. And after 1 month of transplantation, you have viral, fungal and tuberculous infections which are common. So transplant is a multidisciplinary care. We require all the faculties, the neurologists, neurosurgeons, pulmonologists, intensivists, cardiologists, vascular surgeons, and to have a best outcome. Now what we saw was the immediate care, now the long term. So long term care is like any other person, like these patients have hypertension, diabetes, dyslipidemia, cardiovascular disease, infections, malignancy, and chronic allograft dysfunction. So blue are highlighted specifically for the patients with post-transplant settings. Now, if you look here, the immunological factors and the non-immunological for long term. So long term, what we do is we monitor the donor-specific antibodies. So for monitoring the donor-specific antibodies gives us the hint that if the donor-specific antibodies are increasing post-transplantation, then the chances of rejection are high. In such patients, we reduce the donor-specific antibodies by plasmapheresis and make the graft stable. And if you look at the non-immunological factors, if you look the diabetes, dyslipidemia, hypertension, infection, the drug toxicity like cyclosporine, tacrolimus, they cause interstitial fibrosis. So we have to be vigilant about that. Now, if you look here, the patient survival and the graft survival. If you look in living transplantation at 10 years, if you see it is around more than 90% patient survival, and the graft survival is more than 80%. So concluding, immediate and long-term outcomes have improved after kidney transplantation with the modern day immunosuppression. 10 days hospital monitoring is needed. 30-day close follow-up is desirable. After that, we can follow them monthly or 3 monthly. Thank you very much.
Thank you very much, sir, for nice lecture within our precise time. I request Dr. Hemant Shah to felicitate Dr. Kamal Gopalani. Dr. Atit Sharma, who will be speaking on robotic knee replacement. Welcome, sir. Session will be for 15 minutes.
Yes, sir.
Please start.
Yeah. Good afternoon, everyone. Knee replacement is the second commonest surgery after cataract. So everybody here would be definitely knowing about knee replacement. You would be having some patient, relative or a neighbor who has undergone knee replacement. Maybe some here would have got a knee replacement done by themselves, on themselves. So we'll talk about something new in knee replacement, the recent advances, and which is robotic knee replacement. So a conventional knee replacement, which we were doing till now before the advancement of robotic knee replacement, was it utilizes X-ray images and the clinical acumen of the orthopedic surgeon, and it is performed by using jigs and a set of instruments. So this is our knee joint when we open it here. So you have to start something with a reference point. You need a reference point to start the surgery. So the reference point which is taken is the femoral canal. So we drill a hole inside the femoral canal like this, and then the first instrument which is inserted is this. I'll show you the exact instrument. So this is our knee. This is the photograph, and this is the original knee. From here we make a drill hole inside the femoral canal, and this is the instrument which goes inside the femoral canal, and then you take the first distal cut. So when we will be discussing the advantages, this, when it goes inside the femoral canal, especially in cases of bilateral knee replacements, there are some chances of fat embolism. The chances of fat embolism increase because the femoral canal is full of fat emboli. So this was the conventional knee replacement which we were doing when I started my practice in 2000. Next came in the navigation. So the navigation came in about 2011-12. Navigation was an artificial intelligence tool which
helped us to plan the surgery. So the doctor is doing the surgery, but the artificial intelligence would help us plan the surgery, the sizes of the implants, as well as the poly inside, how much you have to cut and how will you balance the knee. After this, in 2014 and 15, came the patient-specific jigs. So they used to take the CT scan of the patient, the MRI of the patient, and then that used to be sent to the company. And from there, these type of specific jigs in sterile containers. And so this was used for the femur and this was used for the tibia. So these were basically a custom-made jigs, specially designed for that patient themselves. Now, what has come, this is the third generation of AI which has come. This is the robotic system. So the difference between the robotic system and navigation is it definitely plans, but it also implements the set plan which we have made. So this is the Cori robotic system which we have at KD Hospital. The name is the Core of Real Intelligence. So at the time when we were procuring this robot, there were two things in mind, that it should be a robotic assisted surgery. The robot cannot do the whole surgery by themselves, because when I tell my patients we'll be doing a robotic, the first question which comes to their mind, sir, robot surgery karse? So then they are afraid that robot surgery karse, there may be some problem in between. So it's the robot assisted surgery. The robot assists the surgeon in doing the surgery. And the second important point we kept in mind is that there should be no CT scan pre-op. It should be directly during the surgery when we plan, because CT scan involves cost, also some radiation. So our the Cori system is useful for the knee replacement, which is its main benefit. It is also useful for unicondylar knee replacement as well as hip replacement also. So all three categories of replacement are done by this Cori robotic system. A small video, I'll present animated video of how we do the robotic surgery. So this is the patient, this is the main robot, the artificial intelligence. These are the infrared cameras which are the eyes of the robot, and this is the tool which helps us implement it. So first of all, you have to put in trackers inside the femur and the tibia for the robot to know where exactly is our limb. These are the secondary markers. So after this, it will ask us the total, so the medial malleolus, the lateral malleolus, the center point of the tibia, the femur, and then the hip rotation. So in short, right from the hip up to the ankle, it knows what alignment our limb is in. Then on table, we can directly mark out the femoral condyle. Immediately, it takes hardly few seconds. Similarly, the tibial condyle. And once everything is marked, which takes about 5 minutes, it will give us a planning of what are the sizes of the femur, the tibia, the poly in between. This is the soft tissue laxity. Apart from the bony cuts, it will help us in soft tissue laxity also. So we can change here as per our intelligence. And then it will help us in executing the surgery as well. So the pink, green and white which you can see, the burr is used to cut the bone, which in usual cases the saw is used. And once you reach the white part, even if you press the burr there, it will not cut any further bone. So it helps in implementing the surgery also. And once this is done, it will give us an exact data of how much flexion we have achieved and what is the alignment of limb we have achieved, the whole motion also. So this is the final which we achieved. What we have done, what we had planned, what we have achieved, and this is the final range, throughout the range of motion, what will be our laxity. So this is how the robot helps, assists us during the surgery. So this we call as the smart knee replacement. Is safe. As I told you before, less chances of flat embolism, especially in cases of bilateral knee replacements. Because in that 2 times the reference point has to be taken and the rod has to go inside the femoral canal. Because we have planned the surgery beforehand, we know what cuts to be taken, what releases to be done, so it's minimally invasive. We do the minimum of incision, minimum of soft tissue release in between. We are using the robot for accuracy so that we can give an accurate result to the patient and the joint would last longer. So see the accuracy here of the tibial cut. It's 0 degrees here and 0.4 millimeters, 0.4 degrees of what we have intended. Within fraction of degrees and millimeters also, this is the amount of accuracy which we achieve. Plus the final result, see, external rotation 1 degree, valgus 1 degree, which we aim at 0 or 1, that we can get with the help of a robot. Because it is a minimally invasive, the recovery is faster, the patient gets back to work faster, the pain is less, and final is the transparency. What we have promised to the patient to give a good surgery, we are giving a perfect alignment to the patient so that the joint lasts longer. So see, this is 5 narrow, 4, and the perfect balance in flexion and extension which we have given to the patient. The pre-op alignment was 7 and we have achieved an alignment of 1 degrees. So transparency for the patient as well as for us also that we have done a good job. So robotic joint replacement is a step into the future. And why do I say it is a step into the future? Initially we used to count on hands, then by writing, then on calculator. Now we have an Excel sheet, and once you introduce something, put the calculation, the answer will come directly. Even in sports, we use a DRS technology, artificial intelligence. Football World Cup is over just now. They were using artificial intelligence like anything. Even in chess, they use artificial intelligence to learn. When it can be used in these games, why not in a surgery, so that we can give a better result, perfect result, long-lasting result. So, though we do the same surgery in all the patients, the same steps, every patient's knee is different. So, the right also is different than the left. Right may have a size 4 while left may have a size 5 narrow. So, it's different in terms of size, deformity, varus valgus, mobility 0 to 90 degree, 0 to 100 degree, and the laxity. So, for practical purposes, I'll show you. This is the knee replacement implant. It's a model, and if you can see, it's just a 20 millimeter implant, right from the femur, poly, and tibia. So the knee replacement surgery is just a surgery of 20 millimeters. So you see, if you are away by 2 millimeters, you are 10% away from your final product. Or if you are 3 millimeters away, then you are 15% away from what you intend to do. Just 3 millimeters. So a robot is used for, artificial intelligence is used for accuracy plus the skill of the surgeon, which will give you maximum perfection. And why do you require maximum perfection? Because the needs are different. People, the first question patients would ask me, so they want to sit on the floor, they want to cycle, they want to play golf, even some want to play tennis. So if the surgery is done well, then the result is good, and then the patient would be able to pursue all the things. So what are the benefits of CORI? As I said, preoperative CT scan is not required. Safe, less chances of embolism, accurate and precise implant positioning, less blood loss, speedy recovery, and increased longevity of the joint. And this was what we were explaining to the previous Prime Minister of UK, how this robot works. This is my team with more than 20 years of experience, all of us are there every time. And thank you so much for your attention.
Thank you very much, sir, for a nice lecture and the latest updates on robotic knee replacement. I request Dr. Vikul Shah to give the memento to Dr. Atik Shah. Nice lecture. Please, sir.
replacement package,
which we are providing at KD Hospital. We are not charging for robotic surgery. The robotic surgery is done at the same cost of what we are doing the knee replacement. No charges, just.
Now I invite Dr. Diwas Prajay for next lecture. His topic is liver transplant, what, when, and how.
Topic is liver transplant, what, when, and how. So the lecture is going to be very interesting. I request the speaker to conclude the lecture in 15 minutes.
Yes,
Thank you.
thank you, sir. So, good afternoon all. Unlike the previous talk, very beautifully discussed with my colleague Dr. Atit Sharma, liver transplantation is not that common as knee replacement, and many of us, including doctors and patients alike, have so many questions and so many doubts about liver transplantation. I'll try to do justice to all those questions in a short time. So to start my presentation, I'll start my talk with two image slides. This image, a 9-year-old girl presented with hepatic coma, grade 4 hepatic encephalopathy on ventilator with acute liver failure. Now, if we go down the line, probably 15-20 years back, this would be the end of the road for her, most likely, because that time the technology was not that advanced to manage such patients. But over the time, in last few years, the technology has taken lots of leaps and bounds. And the second slide speaks on for the same patient who is sitting with me 2 months after we did emergency liver transplant, living donor liver transplant. Her father was the donor. So there were 3 issues in this patient. One was pediatric transplant, a child who was advised emergency transplant. The family obviously is aghast when suddenly, especially acute liver failure, when the patient does not have any history about any liver disease, and suddenly you go to the family and say, okay, your child needs a liver transplant as life-saving measure, otherwise she may not survive. And doing the transplant in emergency. So 3 issues, and the family was very cooperative. They understood everything. They followed whatever we advised, and this child was sitting with me in my peripheral OPD 2 months after the transplant. She is still coming for follow-up. She has finished more than a year after the transplant, and she is doing well, going to school, taking part in all the activities. So, so basically there are 3 major questions. One is what is liver transplant and how it is done. Still, many of us don't know exactly what liver transplant means. Second is which patients need liver transplant. Not all patients with liver cirrhosis need transplant immediately. And more importantly, what is the cost? Because there are a lot of myths that liver transplant costs maybe 40 lakhs, 50 lakhs. But believe me, the cost of the transplant has come down drastically, and I would answer that question straight away, that the cost has come down now to anywhere between 15 lakhs to 25 lakhs. Our hospital does transplant in 15 lakhs, including everything, all the expenses, all the costs included. And the third question is, how are the outcomes of transplant? So that is another important question, because again, we have a lot of misgivings and a lot of ideas among the families, among the patients, that most of the patients do not survive after transplant, and the outcome of transplant is not that great. So just after this, I would like to make a strong pitch for organ donation, because I know as family physicians, you guys, you people are friends, philosophers and guides to most of the patients and their families. And many decisions, many important decisions, including organ donation, are taken in consult with the family physicians. So coming straight away to the topic, liver transplantation, what, when and how. To understand what is liver transplant, first let us understand what is liver cirrhosis and what are the causes. So the causes of liver cirrhosis, as of now and even today, alcohol is the commonest cause for
liver cirrhosis, and still the commonest indication for liver transplantation world over, not only in our country but world over. Another rapidly coming up cause is NASH, non-alcoholic steatohepatitis. A few years back, we used to get a patient, ultrasound incidentally diagnosed fatty liver, grade 1 or 2. And we used to tell our patients, okay, तो 10 patient ने sonography कराओ, so तो 2-3 patient now से, and there is nothing to worry about fatty liver. But this has become a front runner for liver cirrhosis nowadays. Also because of the rapidly increasing incidence of diabetes mellitus and because of our lifestyle changes which have come, including diet changes. Other causes are hepatitis B, C, Wilson's disease, autoimmune liver disease, Budd-Chiari syndrome, drug-induced liver disease, and there are some pediatric causes like biliary atresia and some metabolic causes. What is liver transplant? In one line, liver transplant is replacing a part or whole of a diseased liver with a new functioning liver. And it is done in two ways. One is diseased donor transplant. We take the whole liver from a brain dead donor, and other is living donor transplant, where we take a part of the liver from a living donor, from a healthy member of the family of the recipient, and we transplant it in the recipient. So the first question that we had tried to answer is, when is liver transplant required in a patient with end-stage liver disease or liver cirrhosis? So to answer in short, any liver cirrhosis patient with expected survival of less than a year without transplant, patient who is having liver cirrhosis in our regular follow-up, and when we feel that this patient may not survive for more than a year without a transplant, such patient should be advised liver transplant. Then how do we pick up those patients? How do we know that, okay, our patient can still go on for 5 years, 10 years without transplant, and this patient would need transplant within 6 months? So for that, we need to know about something about compensated and decompensated liver cirrhosis. So compensated liver cirrhosis is a patient having some non-specific abdominal pain, undergoes abdominal ultrasound and is diagnosed to have liver cirrhosis, but does not have any symptoms of liver cirrhosis. And decompensated is a patient with all these symptoms like altered sensorium because of hepatic encephalopathy, jaundice, blood in vomit or blood in stools, reduced appetite, tiredness, ascites, tremors, black stools, edema. So when these symptoms develop, the patient is classified as decompensated liver cirrhosis. And when you see the survival data of liver cirrhosis patient with compensated cirrhosis may go on to live for, on an average, for 9 to 10 years without requiring a transplant. And such patients just need to be in regular follow-up with you. Every 6 months, some set of investigations need to be done, including blood investigations and abdominal ultrasound. And decompensated cirrhosis patients generally have a survival of approximately 1 to 1.5 years without transplant. There are some complications of liver cirrhosis like spontaneous bacterial peritonitis, which is infection in ascitic fluid. Such patients may not survive more than 9 months without transplant. One, patients with hepatorenal syndrome type 1 and 2, where the kidneys are structurally normal, but because of the liver cirrhosis, the creatinine starts rising, the urine output starts falling, and such patients may not survive more than 6 months without transplant, and such patients should be immediately on high priority advised for liver transplant. Then there are some non-cirrhotic indications for liver transplant. I mean, not only cirrhotic patients need transplant, even patients without cirrhosis also may need transplant. And the first thing that I discussed in the first 2 slides, acute liver failure. So there is no history of liver disease. The patient's liver has always been absolutely normal. Suddenly the patient presents with jaundice, and within 26 weeks of developing jaundice, the patient goes into altered sensorium, that is hepatic encephalopathy. So that is called acute liver failure. And the common causes of acute liver failure are drug overdose, most commonly paracetamol, dengue fever, ratol poisoning, there is a rat poison or yellow phosphorus poisoning, hepatitis A and E sometimes can present with acute liver failure. We have done transplant for hepatitis E also, hepatitis E related acute liver failure. Hepatitis B and C, Wilson's disease, alcoholic hepatitis can present as an index presentation in acute liver failure.
Acute ischemia due to shock, patients having prolonged hypotension on high inotropes. Along with other organs, the liver's blood supply is also cut off and the liver goes into acute failure because of shock. Acute fatty liver of pregnancy, that's another important cause of acute liver failure. So then the important question is which patients need transplantation in acute liver failure? Because again, not all the patients of acute liver failure may need transplant. But the patients who need transplant in acute liver failure generally should be transplanted within 48 to 72 hours because that is the window period where you can go in, do the transplant and save the patient. So a lot of things depend on the cause of acute liver failure. Patients with paracetamol poisoning, acute hepatitis A, shock liver, and pregnancy-related liver disease, non-hepatitis B and non-hepatitis C related acute liver failure, the transplant-free survival is fairly good. It is more than 50%. So more than half of these patients may survive without transplant. And in other causes, especially hepatitis B and C related acute liver failure, the transplant-free survival is very dismal. It is less than 25%, and such patients should be immediately advised transplant. There are some criteria. The most popular, the so-called celebrity criteria, King's College criteria, they are based on certain parameters like acidosis, lactate, hepatic NCAF, INR, creatinine, age of the patient, duration of jaundice, bilirubin levels, and etiology of acute liver failure. Clinical judgment is still the best tool to decide, and cerebral edema is the commonest cause of mortality in early period, and sepsis is the major cause of mortality in the later period. Another indication, non-cirrhotic indication for liver transplant, hepatocellular carcinoma or liver cancer. So most common primary malignant tumor of the liver, commonly seen in cirrhotic livers, but it can be seen even in non-cirrhotic livers. The treatment of choice is surgical resection, but there are some patients where because of the location of the tumor or the number of tumors or the size of the tumors, the resection may not be possible, and such patients may need transplant to increase the survival. There are some criteria like Milan's criteria, UCSF criteria to decide whether which patients will benefit from the transplant and which patients will not benefit from the transplant, and transplant would be a futile exercise in those patients. Again, early transplant can be life-saving. One important question to answer is when not to transplant. A patient may require transplant, they are willing for transplant, they have a donor in the family, but still you would like to say no, okay, no, the transplant is not possible. And again, as alluded by my colleague Dr. Boplani, active uncontrolled refractory extrahepatic malignancy or infection is a definite contraindication to transplant. Severe cardiopulmonary comorbidities, renal dysfunction, active untreated psychiatric illness, alcohol or any other substance abuse are definitely contraindications for transplant. Types of transplant, two types, cadaver liver transplant, disease donor liver transplant, and living donor liver transplant. Cadaver liver transplant, organs donated from brain dead donors, and living donor transplant, the organs are donated from a member of the family. Both have advantage, disadvantage. The most important point is there is a waiting period in the cadaver liver transplant, which depends on the blood group of the recipient. So, for example, blood group B and blood group O, the waiting period is approximately 3 to 4 months, whereas patients with blood group AB and A, the waiting period can be as much as 10 to 12 months or even more. According to cadaver liver transplant, there are two important scores which are pertinent for cadaver liver transplant or any liver transplant: MEL score and CAL score. These formulas are given online, and there are ready-made calculators online which calculate the MEL score. So MEL score, I would like to just discuss in short, because in Gujarat, transplantation, the cadaver liver allocation is dependent on the MEL score of the recipient. Higher the MEL score, the better are the chances of that patient to get the liver, and they will get the priority. Again, this study, which was done quite in the past, it is a Western study, and it found that as the MEL score increases, the chances of transplant-free survival decreases. So, an important point from this study is a patient with MEL score of 10. If you see the transplant, okay. So the transplant patient with MEL score 14 or more generally should be advised liver transplant. How to list in SOTO? We have to advise some blood investigations, imaging studies, just let's say ECG, 2D code, DAC, PFT, some fitnesses, some documents required, address proof and photo ID, domicile certificate, and patient is listed. Once the patient is listed, he needs to be in regular follow-up with some blood investigations to be repeated at regular interval and wait for the call. When the call comes, the patient has to reach the hospital immediately and get the transport. This is the incision that we put for organ retrieval. And this is how we pack the organ and transport the organ to the hospital where the transplant is to be done. Living donor transplant, which patients need living donor transplant? Sick patients with risk in bleeding, like acute and chronic liver failure, recurrent infections, complications, acute liver failure, patients with liver tumors. Donor selection, this is an important question which may come from the families that who can donate. So patient should be a related family member, 18 to 55 years of age, blood group compatible. RH compatibility is not required, only blood group compatibility is required, and all viral markers negative. This is how we evaluate the donor in our hospitals with CT scan and all. Post-transplant care, that's another important question that patients ask કે કેટલા દિવસ hospital રહેવું પડશે અને શું ધ્યાન રાખવાનું છે. So patient generally extubated and post-op day 1, immunosuppression started, which has been already discussed with by Dr. Gopani. Patient is kept in ICU for 5 to 7 years, early mobilization. Sutures are removed after 2 to 3 weeks. Patients remain on lifelong immunosuppression. So one medicine at the end of 1 year, twice a day to be taken. Only precautions required are clean water, clean food, stay away from unwell patients and wear mask when you go to public places. They can join work, have children, go for movies, gym, etc. Donors do not require any medication and they can live a normal life. Survival. The success rate of transplant is 90 to 95%. The risk involved is 5 to 10%. And there is no expiry date or no shelf life of the transplanted liver. The liver can work for the whole life. There are some innovations in liver transplant. I would like to skip that for the shortage of time. Organ donation, the last but the most important topic. Why I would like to discuss, because there is a big gap between the supply and the demand and the requirement of the organ. Approximately 2 lakh patients die annually of liver failure or liver cancer, and 10 to 15%, that is 25 to 30,000 of these patients can be saved by timely transplants, but only 1,500 patients undergo transplant every year because of shortage of organs. Same situation is there for renal transplants, heart transplants and corneal transplant. And the important cause for this gap is general lack of awareness about organ donation. The process of organ donation is very simple. Once the family requests that they want to donate the organ, they just have to notify the SOTO, which is the umbrella organization which controls the organ donation procedure. And SOTO informs the transplant team and they come, and generally the whole process is finished within 24 hours. And the body of the deceased is given to the family within 24 hours. The benefit of organ donation, 8 people can survive because of one organ donated. To conclude, patients with liver cirrhosis may live for a long time without needing a transplant. There are definitive indications for transplant. Transplant is the definitive curative procedure for liver cirrhosis, and also for non-cirrhotic conditions like acute liver failure and liver tumors. It gives a normal survival and a better quality of life. Thank you.
Thank you very much for the information. Now I request Dr. Ramesh Jain to give a moment to Dr. Jain. We are happy that Dr. Diwakar Jain told that we general practitioners and family physicians can play the key role in the organ donation. So this is the take-home message we are taking. Now I request Dr. Kavita Manjunath for the taking lecture. The subject is palliative and end-of-life care at home. This is such a very important and sensitive topic. This is a medical and emotions combination. I request Dr. Kavita to start lecture and request to conclude in strictly 15 minutes.
Sure.
Thank you.
Thank you. Good afternoon, all. I know it's a pre-lunch session and we are all waiting for an exciting lunch. I would try to keep it as crisp and short as possible. I am Dr. Kavita S. Manjunath, deeply trying to understand palliative care, and I have my hands in providing palliative care for patients at home. Now, I am associated with this organization, Protea, which is one of the India's largest leading home healthcare company with all medical services under one integrated roof. Let's first understand what is not palliative care. Palliative care is not end-of-life care. It's a care provided to improve the quality of patients with serious illness. Today I'm going to talk to you about what is palliative care, its definition, and why it is important for patients. Let me begin telling you all that death is very common. In India, there are about millions of deaths happening every year, and this number is growing as the population grows. Now, despite this, the life expectancy is good. It's about 70 plus to 80 plus. But, despite the statistics, what we know is everyone will die one day. And the most causes of death have been heart failure, cancer, stroke, lung infection, road traffic accidents, and organ failures, as the previous speaker spoke. Now, these were the causes which people kept dying many, many years in India, and they are the causes which people are dying today, and with what we are living for a long duration of time. You see, there are many treatments available at hospital. They're provided to patients, mainly to make their quality of life much better and help them live longer. The question here is, how can we provide the best quality of life, for patients while they are living with serious illness and as they approach their end of life? We have heard people, asking for good death, praying for good death, the preference is good death. You see, ultimately, it's not about achieving good death. Death is always associated with sorrow, grief, sadness, and loss. In fact, our goal in helping patients at home is to provide a better life with serious illness and a better death than they would have had if we had not involved at all. So that's the focus of care we want to provide, and that's the focus of today's talk. So I'm sorry to tell you all this. For a moment, let's all imagine, at the end of our life, where are we? What are we thinking? Who are we with? How does it look like? Seems a little scary, but if you look at this slide, there are two patients here in the ICU during their end of life. These patients are with lot of tubes connected, tubes going in and out, monitors connected. On the left-hand side, the patient is alone. On the right-hand side, at least this patient is not alone. He is with some caretaker, and this somebody could be a healthcare professional, a doctor, nurse, therapist, or even a family caregiver. But what we know is this is not what we want for ourselves or for our loved ones. So now, how can we, make things different for people who do not want to end up this way? Yet many die in hospital, which include an ICU stay. So now, if you actually get into many, we have seen patients getting into hospital hoping that they get better. They're desperately sick and they end up in ICU. Unfortunately, our treatments don't help and they're too sick to leave the ICU. Now, the challenge here is how can we make this environment more comfortable and peaceful for patients? I'm sure you all will, agree to this, that many of our patients have had multiple hospital admissions, including ICU. So they're again landing up in ICU and this time not making it up. So how can we prevent this happening to people who do not want it to happen? So the best way is to talk to them and ask them what they want to have to happen if they become too sick, and second is a clear communication with patient and patient family. So now, what is palliative care? What's the definition? Now, this definition was brought about by Center for Advanced Palliative Care. Now, this is based on market research. They went out to people, talking to them, asking them what is palliative care, what do they feel important in palliative care, because they wanted to develop a definition which most resonated to people and patients. Nowadays people do not have an idea of palliative care. thankfully this is good because at least they don't have a bad impression on it. So coming the language which we use with the patient, what is palliative care, what we explain to the patient is this. Palliative care is a specialized medical care for people with serious illness. This type of care is focused on providing patients with relief from symptoms, pain, and stress of serious illness, whatever the diagnosis is. Now, the goal here is to improve the quality of life for both patient and family. Palliative care is provided by a team of doctors, nurses, and other specialists who work with the patient's other doctors to provide an extra layer of support. Now, it's appropriate at any stage of illness and can be provided along with the curative care. Now, to be fair, we cannot say all this with our patients because it will take up our major consultation time and we do not have time for it. But let me highlight a few important points here. First, palliative care is for patients with serious illness. Heart failure is serious, cancer is serious, stroke is serious, organ dysfunction is serious, but here it is not end of life care. It is just talking about serious illness. It is not talking anything about death or dying process. Here the patient is able to relate to the serious illness. Second, it is for relief from symptoms, pain and stress of the serious illness. Palliative care focuses on such relief. Perhaps the most important point of this definition is to improve the quality of life. And we have heard the saying that it is not years in your life, it's your life in years what matters. So whatever the life in your years is, either months, weeks, days, or hours, the focus is to provide the best quality of life for as long as possible. The last part of the definition is to provide an extra layer of support. So this is not instead of any other curative or care the patient is receiving. It is in addition to the curative and other care the patient is receiving. So this is the definition which most resonates to patients and makes it important for the patient and demonstrates what the benefits are. So now the next slide talks about concurrent palliative care, how palliative care should look like. Now, this means that the patient should get palliative care along with curative care. Let me explain it to you with an example of one of our patients. Now, we had a 73-year-old male patient who was diabetic, hypertensive, dyslipidemic, fairly controlled sugars with oral medications, family history of diabetes and hypertension in his family, the parents, but no other significant, family history. He was independent with his activities of daily living and instrumental activities of daily living. He was mobile, he used to drive. One night he called us up, the family called us up saying that he's having profuse bleeding per rectum. It was midnight, around 1 a.m. So we had to ask the family to shift him to a nearby emergency hospital. There he was taken to the hospital, his vitals were stabilized, they tried controlling the bleeding and he was immediately referred for imaging studies. He was referred to CT and MRI pelvis with two sections up and below. Now the report came out as circumferential, single intensity, soft tissue enhancing mass lesion in the mid-rectum with perirectal lymph nodes. There was also wall thickening, wall enhancement with transmural extension with multiple perirectal lymph nodes and two lesions in the liver. So, he was referred for ultrasound guided biopsy. This came out as metastasis in liver, primary being carcinoma colon, moderately differentiated carcinoma. So now, thankfully, ethically, the hospital doctors rang us back since and informed us the report, since we were the primary treating doctor, before they could leak out this information to the patient. So now it's our job to take out this diagnosis to the patient, and we did it. The family was actually depressed, there was sorrow, low mood, which is a natural phenomena, the response from anybody who gets diagnosed with cancer. So now we did inform this diagnosis, but there were two questions from this patient. One, he said, "Doctor, am I going to die?" Second, how long do I have? This is a natural question any patient would ask if he is diagnosed with cancer. So yes, is he going to die? Yes, the disease, likely this is a disease which could take his life. Second, how long did he have? He actually thought he had only few weeks to live. But our discussion with him regarding the prognosis of about 1 to 1.5 years was actually a good news for him. It was rather good than what he expected, that is few weeks. We did refer him to oncologist. He was started on chemotherapy. Gradually, chemotherapy made him sick, and the focus of care was more on palliative care. So initially, he was on chemotherapy. Then, as he became sick, the focus was more on palliation. So, in this slide, you can see that either the patient is no longer interested in it, or is it no longer available. Palliative care occupies a major space of care of this patient. Now, this yellow arrow indicates hospice care. Hospice care is for those people who have 6 months of prognosis. I will not get into the hospice care because of lack of time. I'll concentrate on the palliative part. Now, on this right corner, you can see this point, this brown arrow pointing the right corner bottom. This says that on the day of death, also the patient is on curative care. Like in heart failure patients, they are on ACE inhibitors, ARBs, diuretics, and also morphine for their shortness of breath, pain, and discomfort. Now, as per this slide, you can see sometimes there is more care on curative therapy and sometimes more on palliation, but palliative care occupied the major part of care for this patient until death. Now, this orange part is bereavement. We also play a role in bereavement. It is just not the patient, it's the family also becomes a patient, and we have to think of them during bereavement. Bereavement usually gets better with time, generally 6 to 8 months, the acute part of it gets better. But if it persists beyond this, we have to worry that he or her has got a complicated grief. Now this pale orange tone represents that we do not get over with the loss of our loved ones. I feel we should, when family comes back to us, for a follow-up or for any other relative, we should ask them, what are you thinking of your mother, your father, brother or sister, the last one today, instead of asking them, are you thinking of them? Because we know that they are thinking of them every day because it is their lost loved one. So I will say that this is the best quality of life which we can provide, and it should be the goal for our patients. Okay, now what's the evidence that this type of care actually makes difference? That is, getting palliative care along with curative care. Yes, there is an evidence. This slide demonstrates a randomized control study done in General Howard Hospital. They had patients with non-small cell metastatic lung cancer, which is actually a non-curable disease. But yet the patient was started on chemotherapy, non-small cell being a non-curable. Now, half of these patients were randomized to get palliative care at the time of curative care. Now, they tried to analyze them for about a year. Then they realized that the group which were randomized to get palliative care had superior outcomes compared to the other group which had only chemotherapy. Now, what were the superior outcomes? They had superior outcomes in terms of better quality of life, improved symptoms, less pain, less dyspnea, less nausea, less depression. They were less likely to receive aggressive care at the end of their life. That means they were less likely to get into the ICU to get chemotherapy at the end of their life. They had a longer life by 2.7 months on an average. So the survival in this group who got concurrent palliative care, that's a palliative care and curative care, survival was 11.6 months versus 8.9 months in the only chemotherapy group. So I say, if we pursue this kind of care for patients with serious illness, we can help them in all means. We have been actually instrumental, in providing palliative care at home. But is this type of palliative care available for everybody now? Unfortunately, no. Yeah, sure. So there are other illnesses which we can, say that this diagnosis can get palliative care. It's like heart failure with repeated admission, patients with COPD with repeated admission, breast cancer and malignant pleural effusion, metastatic cancer, dementia, aspiration pneumonia, cirrhosis and repeated admission, patients awaiting organ transplant. What we do in palliative care, main 3 domains: palliation of symptoms, clear communication, and psychological counseling. Now, at home, we have been, very meticulous in providing this care because it's structured, it's protocolized, it's under supervision, nurse-driven and doctor-driven. There is family and patient empowerment, and it acts like a long-term medical care unit. Now, there are different scopes at home health care. There's chronic illness, business management, monitoring, post-hospital discharge, recovery process, post-operative care at home, and certain preventive care checkups. Just to give you another study which was done to study the importance of aftercare medical service at home and rehabilitation care at home. This was a study done on long-term mortality and outcome in hospital survivors of septic shock and sepsis and severe infection. They studied 84,000 of patients who were discharged from hospital after sepsis and septic shock. They realized that 5-year mortality, actually was reduced in this group of patients who went into aftercare programs at home and rehabilitation services at home than those who were just discharged for self-care at home. So, in conclusion, palliative care is a medical care focused on promoting quality of life in patients with serious illness, and it should be provided alongside with other curative and appropriate treatment and care. Thank you.
I request Dr. Vijay Maurya to present memento to Dr. Kavita Manjunath for giving most informative lecture. So, Dr. Kavita Manjunath to give a memento to our reputed chairpersons of this session. First of all, I request to Dr. Hemansha to receive a memento for the reputed of the session. Please. I request Mr. Ryan Gillen to receive a memento, please. Request Dr. Suresh Patel to give a memento to Dr. Rapul Shah. I request Dr. Kevur Shah to give a memento to our Reputed Appreciation Dr. Hemant Shah. Thank you very much for the cooperation. Now to wonderful and exciting news or information for all audience. Number one, that as routine last time we conducted the quiz session. This is again we are going to conduct. And secondly, in the after post lunch there will be a mega bumper lucky draw that will be 1.5 lakh rupees costing something gift or prize. So after lunch, all are requested to attend all sessions in Hall A. Now I request our media person to release the second quiz. As the general information I given earlier, all are supposed to log in www.afpa.co.in/hall B from the Chrome browser or any whatever available in their Android or Apple mobile browser. You will get a question with the multiple choice answers. One answer they are supposed to submit. The person will be declared winner who will submit the correct answer at earliest. The earliest answer will be registered in our system and we will declare it soon. Already time has been started. Maximum time is 2 minutes. One minute has been lapsed. we received more than 10 correct answers. The winner will declare Dr. Amit Thakur. Please come on stage and collect your prize. Given instruction not to declare question as well answer from my end, I should not know it. Otherwise, I may leak and declare to some of my friends. So that Dr. Viren Mehta will elaborate all matter. The question, which drug level monitoring is done routinely post-renal transplant except choice were number one, cyclophosphamide, the second was everolimus, C was a third was a tacrolimus, and the fourth was prednisolone. So right answer prednisolone, student. Thank you very much. Now we are starting the last session of the pre-lunch of KD Hospital Symposium. I request Dr. Dilip Tanna, if present in the hall, Dr. Praful Patel from Nadiad, and Dr. Sandeep Shah as a reporter of the session. Request first lecture by Dr. Bhavik Kausar. The topic is do's and don't in fungal skin infection. It is going to be very interesting lecture in our family physician general practice. So hope it will be very useful and informative. So kindly note session will be just 15 minutes. Please conclude your lecture in 15 minutes. Thank you.
Sure. First of all, I would like to offer my obeisance to the divine in you. Thank you, the organizers, for inviting me to deliver my views regarding fungal infection at this juncture. So, the topic is all about fungal infection, do's and don'ts, and recent advances. So, without wasting time, I would like to start the talk. Dermatophytosis is very common nowadays. Previously, it used to be less than 4% of the dermatopathy. Nowadays, as much as 27 to 30% in our OPD. In India, it has been common infection. It was safely amenable with few drugs previously, but now it's not the scenario. However, in past few years, we have seen tremendous increase in the number of patients with recalcitrant fungal infection, not easily treatable by routinely available antifungals. The problem has been worsened for us because of many factors, and out of all, the most important one is inadequate treatment and irrational use of topical steroid combinations. Dermatophytosis is previously, the slide itself shows it was an innocent fungus initially, say about 10 years ago, and now it has been increasing like monsters. Yeah, so it was very difficult to treat even for a dermatologist nowadays. This is a simple picture showing how the fungus invades. It liberates keratinase enzyme, which digests the keratin of the superficial skin, and it invades inside the skin. So reasons for recalcitrant, we all know how to treat it. Still, it is not giving response up to the mark. So what are the reasons? Few probable reasons. As far as patient's factors are concerned, steroid and irrational combination, as I already said, not looking for involvement of the other hidden sites, overcrowding, ping pong effect from mother to son, son to father, etc. Change in the fashion, like a lot of tight clothing and a lot of elastic fibers containing clothes, a lot of jeans is getting popular nowadays. As far as treatment factors are concerned, which are responsible for resistance, is non-compliance, poor penetration by topical preparations, bioavailability of the previously used inadequate treatments, inadequate dosing. They are telling that take the dose properly for say about 1 or 2 months and they are not taking it, inadequate dosing. It is very important as far as resistance of antifungal development is concerned. Polypharmacy and comorbid conditions. So there is a simple slide how to classify superficial fungal infection causative organisms. Most commonly it is dermatophytes. Apart from that, candida and malassezia are one of the factors. But out of all dermatophytes, the most common is trichophyton species. If we take culture of that particular involved area, it is trichophyton which is most commonly found nowadays. Now, in trichophyton there are many species, but two main commonly found species. One is Trichophyton rubrum, that is T. rubrum, and T. mentagrophytes. Now, most of the studies previously was conducted on Trichophyton rubrum. Right? And in recent years, it has been found that Trichophyton rubrum is getting decreased, and the emerging fungal species is not Trichophyton rubrum, it is T. mentagrophyte. So our whole research and all has been conducted on T. rubrum, and now it has been changed to T. mentagrophytes. So that's why that old dosage, itraconazole for 10 days, fluconazole once a week, etc. is not working. In an interesting study, it has been found that T. rubrum survived for less than 12 weeks in a towel or in some utensil, and it has been more than 25 weeks as far as T. rubrum T. mentagrophyte is concerned. So it is more fatal, or not fatal, more morbid, and more survival rate is there. This is the chart showing the increasing amount of T. mentagrophyte. Right? The red bar is stating the emerging trend regarding the T. mentagrophyte species. Now, this is the common scenario. Previously, a small few centimeter sized fungal infection lesions nowadays are getting more and more giant. All over the body, more than 10% of the body surface area involvement cases are not uncommon nowadays. Right? So large size lesions and tinea crudis and corporis are getting more and more common. This is the culture. I think nobody is that much of concerned about it, but ergosterol plays a major role in fungal cell structure. Now, what should an ideal antifungal we are looking for? What should they do? It has to be a broad spectrum active, potent antifungal activity. It has to be a fungicidal agent rather than fungistatic agent. Highly effective against T. mentagrophyte. Long skin retention time. High mycological and clinical cure, and lack of fungal resistance and safe. Right? Should be well tolerated. So management, proper diagnosis, appropriate topical drugs, appropriate systemic drugs, proper drug dose and method of application, proper duration, combination therapy, family screening, very important. Screen for factors compromising immunity, and stress on compliance, that is very important. If we are giving all the treatments in proper, but patient is not compliant, no fun. Diagnosis is very simple. Take a smear, KOH smear, 10% KOH, pour it, and with the help of simple microscope, we can find this type of fungal hyphae. Management is a contagious disorder, communicable disorder, so as corona, simple general measures plays a very, very vital role. So personal hygiene, very important. washing your clothes and linen in a warm or hot water, avoid sharing of clothes, clearing and mopping of the house properly, avoid synthetic and tight clothing, and control of comorbid conditions. Very, very important, though it doesn't seem to be. General guideline we all know, but still, choice of antifungal depends on pharmacologic property, the history of exposure and antifungals, and the site of extension and the lesions. Though there are many slides to follow, but as we're running short of time, I'll not go in detail with it. There are four main pillars of this antifungal oral treatment. Only four drugs are freely available. Voriconazole is though available but not freely. So itraconazole, terbinafine, bisulfilin and fluconazole. Now in first column, the recommended dose. Itraconazole 3 to 5 milligram per kg per day. Right, but nowadays we have to give 100 milligram BD for as long as 4 to 6 weeks, or even in some cases more than that. Terbinafine is recommended 250 milligram OD. We give 250 BD for the same 4 to 6 weeks. Bisulfilin 10 to 20 milligram per day, per kg per day, but that is a recommended dose. Nowadays generally it is very resistant, so we come across with cases which are already resistant, we don't give it. Fluconazole, though we use it 3 to 6 milligram per kg per day. Initially dose was 150 milligram once a week, then it came to twice a week, then 150 milligram once a day, 200 milligram once a day. So it has been increasing like anything because the fungal is not giving response to the conventionally recommended dose. Topical, as far as topical treatment is concerned, clotrimazole, ticagrelor, biconazole, miconazole, and terbinafine, amorolfine, and butanafine, these are the commonly available. Oxyconazole, again one more. See, as far as proper oral antifungal has been selected, the topical antifungal plays a very less role. A simple antifungal agent like clotrimazole or miconazole can do what your laliconazole can. So first thing we should keep in mind, it should be cost effective. 10 gram of tube is costing 100 rupees, and this whole area, 10% of the body surface area is involved. It is not a proper choice to go for a costly antifungal. Rather than we can consider something which is cost effective. So this is again clinical. Clotrimazole is as good as iconazole or something like that. So clotrimazole comparable efficacy is there. Now, advantage of super bioavailable SB preparation you must have heard about. SB 65, SB 50. First advantage as far as pharma company is concerned, it is an important step to skip from DPCO. 100 milligram is now becoming DPCO in few months to go. So 65. But as far as the clinician concerned, no acidic medium is required. Right? So Coca-Cola is not necessary. So improved bioavailability, SB is there. No interaction with food, no interaction with gastric acidity lowering agent, and less intra and inter-subject variability, and improved clinical efficacy. In my experience, I have seen that 65 SB gives as good result as 100 conventional preparation. I don't recommend 50. 50 is slightly inadequate. 65 SB is good. Few slides to go. Special scenario. Now somebody is pregnant, somebody is lactating, and have got extensive fungal. What to do? Right? So, though book says topical is recommended, but topical is not sufficient. Nobody gets cured with topical agent. So, if you want to add oral, in case of pregnancy, terbinafine is considerably safe. In case of lactation, fluconazole is safe. Itraconazole is though not safe for any of this condition. Infants and children, again, fluconazole. Sure. Bisulfilin and terbinafine is safe. Child more than 6 months or 1 year of age, now the recommended itraconazole can be given. In case of liver and hepatic or elderly patients, also we have to titrate the dose. Right, so fluconazole is recommended as a relatively safe option with hepatic dysfunction, itraconazole is comparatively safe in renal dysfunction, right? And in patient with cardiac illness, terbinafine is preferred over itraconazole. So these are the things. Now it is very important to know what is not fungal infection. Itraconazole and fluconazole giving in every patient increase the resistance, nothing else. So these are not fungal infection. These are called eczema, lichenoid eruptions, last stage of psoriasis, stage of atopic dermatitis, no role of antifungal, preserve antifungal agent for future days to go. This is again pityriasis alba, not antifungal needed. These kind of combination, I strictly condemn the use of combination drugs. Itraconazole and fluconazole and micronazole combination with clopidogrel, the potent topical steroid, give rise to this kind of stuff. Severe stria, these are not book pictures, they are my own patients. Severe stria, these are not reversible. Patient will blame you for entire of his or her life for this kind of stria with clobetasol. Now, these are the steroids which should not be used, rather any of the steroids should not be used, but halobetasol, clobetasol, betamethasone, these are potent topical steroids, should not be used at all in case of fungal infection. Though you can take advantage of hydrocortisone or dazonide or sometimes mometazone in inflammatory tinea infection. Itraconazole, with a drug interaction, I think you must be quite aware of it. Now, what is the ray of hope? After itraconazole, what next? If itraconazole is resistant, what next? Voriconazole is available, not freely, but it is still available. Posaconazole is again in pipeline. Amphotericin B, a safer variant of amphotericin B. Deoxycholate is again in pipeline. And caspofungins and fluocytosins. These are the things which are in pipeline. So, last take-home message, proper diagnosis is must. Wherever antifungal is indicated, then only you should give. Proper counseling is very, very important. 4 doses and 5 doses or 5 days of treatment of itraconazole does nothing except it increases the fungal resistance. Patient's compliance. Patient compliance is very important. Never use potent topical steroid in combination with antifungal. Always take care of our quality of product prescribed. A low quality itraconazole again causes lot of resistant cases. So a good quality itraconazole is must, and limit the use of topical and oral antifungals wherever it is not indicated. Thank you.
Thank you very much for giving a very informative lecture. I request Dr. Sandeep Shah to give memento to Dr. Bhavik Kaushal. As such, there is no question answer session, and even I didn't allow to anybody. But in this session, if anybody is having any question, they can ask. I request Dr. Jayendra Kapadia to take lecture on oral vaccination. Welcome, Dr. Jayendra Kapadia, sir. Scenario after COVID, general community as well as the doctors have started understanding importance of adult vaccination. Dr. Jamil Kapadia will deliver a very useful lecture. I request to start lecture and conclude with strictly in 15 minutes, please. Please proceed. Thank you.
Thank you, Chairman Sir, for having invited a very very senior family physician to deliver a talk which is going to be very useful to all of us in our day-to-day practice. Adult vaccination. When meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. This was by Louis Pasteur. Why did he say like this? The myth is vaccines are only for children, but now the COVID has taught us that vaccines are recommended for all ages, including adults. Let me introduce. Today, many adults are trying to improve their health and wellness by adopting various ways. For example, exercising, eating balanced diet, adequate sleep. But they are unaware that the key part of being healthy includes staying up to date on their vaccination. What are the benefits of adult immunization? It improves quality of life, reduces morbidity and prevent mortality, develops and maintains herd immunity against the communicable disease, elimination or control of disease from community and country, what we have realized during COVID-19, prevention of disease outbreaks, and importantly, health-related cost, very important to individual as well as for the nation. Which vaccine an adult may need? We know much everything about the COVID-19, but what I am going to tell you is very important. The Center for Disease Control of Prevention and recommends that adults should be vaccinated against 14 diseases. The Indian guideline of vaccination in older adults, developed by Geriatric Society of India, has also come out with a recommendation. You can go on the website www.geriatricindia.com. Vaccines recommended for adults are pneumococcal, flu, that is influenza, diphtheria, pertussis, tetanus, hepatitis A, hepatitis B, HPV, typhoid, and the optional vaccines are MMR, meningococcal, chickenpox, and herpes zoster. Pneumococcal, let's take by one. But the important, I'm going to tell you which vaccines we should advocate to our patient as a whole in the society. Pneumococcal vaccines, if you could help prevent pneumococcal pneumonia, wouldn't you vaccinate with Prevnar 30? The answer is yes. What are the causative organisms? Streptococcal pneumonia, Indian population, 60 years will be doubled in size between 2001 and 2026, just 3 years. Today we are in 2023, and adults will account for 12.70% of overall population by the year 2026. So, the host factors are immunosuppressive conditions such as HIV, congenital heart disease, immunodeficiency and malignancies, bone marrow transplantation, organ transplantation, sickle cell disease or splenectomy, renal failure and nephrotic syndrome. Immunocompetent chronic heart failure due to various causes like coronary artery disease and cardiomyopathy, chronic pulmonary disease, that is COPD and emphysema, hepatitis C, chronic liver disease, cirrhosis, diabetes associated with CVD or renal dysfunction, they all need this vaccination. Pneumococcal disease manifests as pneumococcal pneumonia, otitis media, sinusitis, meningitis, and bacteremia. The vaccine recommended for adults is Prevnar 30. Well, I'm giving you a trade name also because this is the most widely and most popularly used. There are two types of vaccine. That is, one is polysaccharide conjugate vaccine, that is PCV30. And the second one is 2001 PCV7, which was modified into vaccine, contain capsular polysaccharide from 30 pneumococcal serotypes of pneumonia. Vaccine, that is Pneumovax 13. The schedule of vaccination. PCV13, that is Pirina 30, is administered in the dose of 0.5 ml intramuscularly. The preferred site is deltoid muscles of upper arm. It is recommended for prevention of interstitial pulmonary disease, pneumonia, acute otitis media caused by 13 pneumococcal serotypes included in the vaccines. The next one is influenza. Very important. Influenza or flu is an acute contagious viral respiratory illness mostly ignored. The vulnerable segments, 65 years of age, pregnant women, people who have asthma, neurological and neurodevelopment conditions, chronic lung disease, heart disease, blood disorders, chronic kidney disorders, and chronic liver disorders. The schedule for vaccination, Vaxigrip, the name of the treatment vaccine, it is given only once as a single dose of 0.5 ml liquid in a pre-filled syringe to the elderly population. This is given intramuscularly injection in deltoid muscles. The recommendation, influenza vaccine is recommended administered every year annually because of the changing variant of the disease. The next one is hepatitis A. As you all know, it's a viral infection of liver spread from person to person by a contaminated food or water or a fecal-oral route. Hepatitis A vaccine administered 2 doses, 0, 6 plus 18. It is a combined hepatitis A and hepatitis B vaccine is also available. That is known as Twinrix. Administered 3 doses if it is combined 0, 1 and 6 months. The new Chinese vaccine, which is routinely used in our practice, is BioVac A, that is a single dose provides. There are single antigen vaccine, HIV vaccine, and combination vaccine, hepatitis A and hepatitis B antigens. Vaccination schedule 2 doses and 6 months trials apart. Hepatitis B, it is available as Genivac B. We all know the hepatitis B vaccine indicators, people who live in areas with high endemicity for hepatitis B, occupational or recreational blood exposure, travelers to area of high hepatitis B endemicity, sexual exposure, very important, sex partners of hepatitis B patient, promiscuous sex, STD clinic patient, and IV drug users. Patient on hemodialysis, person with diabetes more than 60 years, less than 60 years, and sex partners of HbA1c carrier. Hepatitis B vaccine is available in recommended vaccine for immunocompetent adult. 20 microgram is administered 0, 1 and 6 as an intramuscular injection in deltoid region. Booster dose does not routinely recommended. Chronic kidney disease patient, CKD, with declining antibody titers, a booster dose is recommended. Many times the nephrologist advise 2 vaccines simultaneously on one this deltoid region and one this deltoid region. Very important. One size fits for all, definition no longer applicable. That is what I am going to talk is about Tdap vaccine. Tetanus, diphtheria and pertussis component. Till date we were using for the pediatric age group. This is for now adult group also. Tdap, the whole cell pertussis vaccine is not used in adult because it is adverse effect. That is not used in adults. Acellular pertussis vaccines are effective and less reactogenic, recommended in adolescents and adults as a combination vaccine. Tdap vaccine has shown 92% efficacy. 0.5 ml is administered intramuscularly in deltoid region. Tdap vaccination to be deferred in unstable neurologic conditions. This is available as a Tvac, that is 0.5 ml for adult up to the age from 18 to 64 years, even more than that. The booster dose of TB vaccine every 10 years till they need it. Many times we give tetanus routinely when a patient comes with injury. That is no longer is advisable now. You can use this vaccine every 10 years in elderly patient. This is not what I'm going to talk is human papillomavirus vaccine, not included into adult vaccination because it's a very, very important vaccine. That's why we have included in this particular segment. There are vaccines, Gardasil and Cervarix. HPV infection, we all know papillomavirus infection is precursor of cervical cancer. Three cancers are 100% curable: breast cancer, prostate cancer, and cervical cancer. But we have a vaccine for cervical cancer. Prevention, 3 doses, 0, 1, and 6, 2 vaccinations available, Gardasil and Cervarix. Quadrivalent and bivalent to be initiated by 9 to 12 years. The catch-up vaccination is up to 45 years. This is a cervical cancer and importantly for genital warts. HPV vaccine effective only type 1 has not previously acquired HPV 2, 4 or 9 in women, 9 to 12 years. Genital warts 3 doses series, 0, 1, 0, 2 and 6 months. Before the ideal age of administering these vaccines, before the first sexual intercourse or the woman becomes sexually active, this is the right time to complete the dosage. Now optional vaccines, meningococcal vaccine. Those who are getting students who are going abroad, the Menintra vaccine is mandatory for them. So many times they come to us for this vaccination. So we need to know about the meningococcal vaccine. Conjugate vaccine preferred for adults with any of the preceding indications who are less than 55 years, although the meningococcal polysaccharide vaccine is an acceptable alternative. Chickenpox, that is known as Varilix. 2 vaccines are available, live attenuated and vaccine with 2 doses, 4 to 8 weeks apart. Herpes zoster. Herpes zoster vaccine is being advocated for adults who aged 60 years and above, who are at risk for developing recurrent herpes zoster as a patient with CKD, diabetes mellitus, rheumatoid arthritis, COPD. Single dose is advocated. Typhoid vaccine, important for all of us. There are 2 types of vaccines available, that is Typhobar. It is available as 2 preparations of typhoid vaccines are available, oral live attenuated strains and inactivated capsular polysaccharide vaccines, 0.5 ml single dose. My dear friends, the Family Physician Association Surat has taken up this is a project for adult vaccination. We have a group of doctors.
Finished remaining.
Yes, I will finish before that time. Because this is very important and we have a project called Buzurgo Ka Hum Safar. And we, myself, my Dr. Vinod Shah, Dr. Deepak, Yatish and Dr. Pragnesh, we all go to the senior citizen club and motivate them to take these vaccines. This is a public awareness because we need to motivate people. Unless and until they are, because they are not motivated, they are not going to come forward with the vaccine. And I'm very happy to say that in that is there are 4 senior citizen groups we have been able to vaccinate with Previna 30 and rest of the major 4 vaccines. So my message to you, take up these, who you belong to, whatever the organization or Family Physician Association you belong to, but take adult vaccination as a part of your public awareness program, which is very important as a part of public service, which the Family Physician always impart to the society. Finally, let me give you the cost of vaccine. Pneumococcal 4,000, influenza 2,200, TTF 1,300, hepatitis A 1,800, hepatitis B only 92 rupees. HPV, that is Gardasil, that is 3,900, typhoid conjugate 1,550, polysaccharide, that is 225 only, MMR 600, chickenpox 2,100, and meningococcal, that is Minetra, wants to be taken in lifetime, 5,440. Don't go away with the cost. If you motivate, people are always going to come forward. And we have tied up kind of with a dealer, and they always provide at a concessional rate. My dear friends, I am thankful to Dr. Vinod Shah, who has been helping me in creating this particular presentation, Dr. Deepak, Dr. Yatish, Dr. Pragnesh, and Dr. Abhay, and many of us who have taken up is a project or a public motivation program, and adult vaccination is a time and need of an hour to all of us to know about the adult vaccination. Thank you very much.
Thank you very much, sir, for giving nice lecture and social drive. Now I request Dr. Dilip Khanna to felicitate Dr. David, Dr. Jain Kapade. The last session, but still our quiz is remaining, so please stay for a couple of minutes. Now I request Dr. Vimal Kumar to give memento to Dr. Sandeep Shah. As a rapporteur of this session. Dr. Pratik Shah to give memento to Dr. Dilip Khanna. Once again, thanks to all for subscribe. Until the last session, I really happy to see all the good number of delegates and viewers and members. Now, not last but not least, our routine session. As already all of you know, the procedure to take the participate in the quiz session. As displayed on screen, everyone has to log in through their web browser, Chrome or any browser available in Android or Apple phone, www.afpa.co.in/all. You will be seeing one question with 4 answers. It is a multiple choice question. You are supposed to select one correct answer and submit it. Total 2 minutes of session already has been started. Winner of the quiz will be selected and declared on the basis who submit the correct answer at earliest. All the submitted correct answer will be registered over here in the system. Already 1 minute has lapsed. Please remaining delegates submit as early as possible. Okay, 2 minutes has completed. We have got the results of the correct answer. As such, more than 10 to 15 answer we getting correct answer. But the first one we received and registered through Natcon. Please come on stage and collect your prize. See you all after lunch in Hall A. Mega prizes of more than 1.5 lakh awaited over there. So don't miss it. Thank you. Thank you.